Harbans.
Hi, Lalit. How are you?
Welcome, sir. President, sir.
Hello, sir. Welcome, sir. Good evening.
Good
Good
evening.
evening, Harbans,
Good
sir.
evening, everybody.
Hello, sir.
Hi, Rajesh. Good evening, everybody. I think it's going to be a marathon webinar.
Yeah.
We have to be very strict about it.
Yeah.
We are so many talks. I hope you are able to finish on time.
We are like,
Welcome, Vivek.
I think only thing is, I think probably little lesser topic. I should have divided into two parts and try to finish in time and maybe some time for the discussion. I will just wish you all best of luck. And one very important announcement, in fact, two announcements.
Sir,
One
we
is,
will finish off the, let us initiate the webinar.
okay.
So will we go?
Let me finish, then you can start the webinar.
No, I think we are live.
sir. We are live.
We are
sir.
live.
We are live.
So,
Yes,
So-
Prashant.
good evening and welcome to the very first webinar of Team ARC 23-26. Team ARC AIOS welcomes the President and GC of AIOS for today's webinar. Today we have stalwarts of All India Ophthalmological Societies and as well as VRSI, that is Dr. Harbans Lal, the current President of All India Ophthalmological Society, immediate past President Dr. Lalit Verma sir, and our Dr. Shobhit Chawla, past President of VRSI. And I'm really thankful to them for gracing today's webinar and agreeing to be with us. Welcome, sir. ARC AIOS will be hosting niche webinars on various subspecialty on every third Friday of the month from 7 to 9 p.m. The webinars would not be necessarily just didactics. We plan to have ample of discussions, debates, and much more in each program. Our very first webinar is obviously on retina, as 50% of our new team of ARC is dominated by vitreoretinal surgeons. That is Dr. Tinku, Dr. Srinivas, and myself. Today, we have the speakers and chairpersons who are the who's who in retina and a mixed bag of seniors to junior vitreoretinal surgeons. But of course, all of them are ace vitreoretinal surgeons of our country. I welcome them all. Now, I request our President, Sir, as Dr. Harbans Lal, sir, to say a few words. Sir,
Thank you, Prashant. I'm very happy and I think you've got a very young and a very dynamic team. And I've got a very young and a dynamic chairperson as chairman ARC. And he's highly enthusiastic. In fact, all of my GC is very enthusiastic in doing the and taking the IOS forward. And you are into really exciting times. And we are going to introduce a lot of new things during this tenure. And for this, we need cooperation of all of you. To start with, I got just two announcements to make. One is that on 31st of July, we are going to have the special GBM. This will be regarding concerning the conference. On the request of many of your members, I'm trying to prepone the conference so that we can have a right weather for our conference instead of June into the March. And there are some other things about the conferences which we will like to discuss in that special GBM. And secondly, all our GC, particularly the managing committee meeting we had, where a lot of new thoughts have come up, we'll put into the place, like for Vision 2030, what we think, how the IOS should work for us in 2030. So we are going to have brainstorming on that. We'll have a physical meeting for that on the coming of the 19th or 20th of August. And then starting from 1st of August, we are going to have the live yoga session, which will be available to, you will get the link, all the IOS members. And the managing committee had the first-hand feel. The yoga teacher, we have got one of the best in the world you can imagine. I've been personally going to his classes and he's a fantastic guy. So I like you people to spread that word so that more and more people can join. And we are seriously looking into the TPA insurance and a daycare center. For that also, the physical meeting is being planned. And of course, me and Prashant Bamankule and GC will discuss how to take the research forward. With these few words, I wish you all the best and continue with your program. Thank you very much for giving me the opportunity to speak.
Thank you, President, sir. Now I would request today's coordinator or moderator for the today's whole webinar and the person who has put in a lot of efforts to get all the stalwarts from our country together on this today's platform, that is Dr. Tinku Bali. And of course, she will be ably assisted, or with her will be Dr. Srinivas Joshi, another dynamic vitreoretinal surgeon and a member of our team ARC, who will be taking forward the further proceedings. Over to you, Dr. Tinku.
Thank you, Dr. Prashant. Well, in the beginning, I would like to thank all the audience who has joined us this evening. I also thank the eminent chairpersons and the speakers who are with us. Well, as you know, endophthalmitis is a dreaded complication that's always lurking in the background whenever we do a surgery. And you're bound to meet this complication at some point in your surgical journey. They say that forewarned is forearmed. So when you do meet this complication, it's best that you have all your armamentarium together so that you can vanquish this enemy before it overpowers you, or more rightly, the patient's eye. So it is to this effect that we decided to organize this webinar on endophthalmitis. As you know, today, more and more people are exposed to the risk of endophthalmitis, presumably because of the increasing use of anti-VEGF injections. Most of our treatment paradigms hitherto were based on the endophthalmitis vitrectomy study of 1995. But over the years, most of us are changing our treatment patterns because we have better antibiotics, better surgical techniques, better diagnostic methodologies. In spite of all this, our visual outcomes are sometimes very poor. Can we improve our outcomes? Can we recognize endophthalmitis earlier? Can we do something better? So that is what we'll be discussing threadbare in this webinar, which tells us what, when, and how of endophthalmitis. I welcome our chairpersons, Dr. Lalit Verma, Dr. Shobhit Chawla, and Dr. Preetam Samant, and all the other speakers who have kindly consented to be a part of this webinar. And I'd like to start by inviting Dr. Parveen Sen. She's an eminent senior vitreoretina consultant in the Dr. Agarwal's group of eye hospitals, practicing in Chandigarh. And she will be giving us a very enlightening talk on the practical aspects of endophthalmitis. And she'll be telling us a practical approach to manage endophthalmitis. Over to you, Dr. Bar.
Tinku, before everybody starts, I think 7 minutes is the upper limit time for everybody, because there are 16 speakers here and we have already exhausted 10 minutes.
Yeah.
Okay.
Good evening, everyone. So I thank you, the ARC team, for this very selection of a very good topic, which is a most unifying topic between all anterior and posterior segment surgeons. And thank you for giving me this opportunity. So without wasting any more time, my talk is basically going to be an introduction to the subject. I will introduce various aspects of endophthalmitis, which the subsequent speakers will discuss in detail. And we know that endophthalmitis can be present in various settings. Post-operative is the most dreaded one. And this can be devastating not only for the eye, but also for the ophthalmologist, for us as well, because it can draw us into a long drawn legal battle, various panel discussions where everybody's, we are talking as to why it happened and why did not. But without going into the blame game, as Dr. Tinku said, it is not a never event. If you are doing your surgery at some point of time, you will encounter it. And occurrence of endophthalmitis does not always mean substandard care. Having said that, it is important that all of us take adequate measures to prevent this complication, to understand this. The basic pathophysiology is that once the infection does happen, the bacteria is lodged into the eye. You may not get immediate signs because there's an incubation period of 16 to 18 hours during which the bacteria proliferate, breakdown of the aqueous barrier, and then it is followed by the typical signs. And the severity of disease will depend upon the virulence of the organism, inoculum of the bacteria, time to diagnosis is the most few important things. Most common source is actually the patient's own surface flora most of the times, followed by contamination of surgical instruments and surgical complications. And sometimes you could probably identify the source, especially in a cluster endoph. If you are having a fungal cluster endoph, you could think of a faulty air conditioning, or if you're having a cluster of pseudomonas, you could think of contaminated fluids, so far, so on. But of course, it is these are all directions, some suggestions which can be taken Most common is the coagulus negative staphylococci, followed by the Staph aureus. But these may be different from different regions. This table I have taken from a ESCRS study, which shows you that in India, actually, we may have very high rates of gram-negative endophthalmitis. So it's not necessary that if the worldwide more of Staph aureus is seen, we should also see the same thing in our group. Pain may not be present in almost 1/3 of the patients, and blurring of vision is almost always present in 90% of the cases. This, along with some amount of lid edema, should definitely worry you whether you are looking at infection. A mild form of infection such as this is how most of the Staph aureus presents, and the posterior segment or the vitreous cavity may be clear, in which case sometimes it is difficult to differentiate it from TAS. Few things which you can consider when you are differentiating is that TAS is usually present within the first 12 hours, and when it is most commonly due to ophthalmic surgical devices or infected or faulty ophthalmic contamination of instruments or incorrect ocular medication which has been used. So most common feature they say is the limbal to limbal involvement of corneal edema is usually goes more in favor of TAS. Though these are some differentiating features, but most important thing is that sometimes it can be difficult to differentiate the two. You could have a delayed TAS as well, which could be because of the surface coating of the intraocular lenses. So most important thing for TAS, prevention is the key. Having said that, it is difficult to differentiate TAS from endophthalmitis. So before you go on to a conservative treatment, must keep in mind that you must not waste any time in giving a trial of corticosteroids. Take a sample from the eye and then start your empirical treatment and rule out endophthalmitis in all cases of TAS. That is the most important carry home message. Empirical treatment could be in form of vancomycin, ceftazidime, and dexamethasone. For fungal endophthalmitis, if you're suspecting, you could choose any of these, but these days, most of us use voriconazole because of its broad spectrum of activity. Response to intravitreal injections could be good, but sometimes you may end up doing vitrectomy if the patient does not respond to intravitreal antibiotics. And if the vision is less than LPL, then definitely, as per the EVS criteria, vitrectomy is indicated. But these days, we do not just do vitrectomy for only PLIs. We have seen that early vitrectomy, especially if the patient is not responding to intravitreal antibiotics, there is no view on endurance ophthalmoscope, or it's a diabetic patient, or it's a virulent organism, we take up the patient early for vitrectomy. Not only do we take up early, but as advocated by EVS, we were just doing a core vitrectomy earlier. Now we are doing more radical vitrectomy so that more and more virulent material can be removed. So these are some advantages of early vitrectomy, which will be discussed, I think, in the subsequent sessions of surgical management. Special situations like fungal endophthalmitis, traumatic endophthalmitis, endogenous endophthalmitis, endophthalmitis with the abscess, neonatal endophthalmitis, these may need early intervention. Bacillus cereus, especially the traumatic endophthalmitis, you may have to do vitrectomy as early as 4 hours. And if there is a retained intraocular foreign body, even if it is a 6/5 vision, you may still need to do an early vitrectomy. Fungus endophthalmitis, vitrectomy really helps to debulk the load of the fungal infection. So these are some examples who do well with surgical intervention combined with intravitreal antifungal agents. So especially if you have corneal involvement with endophthalmitis, again, you may need a surgical intervention very quickly because your view is going to be hampered. But sometimes in presence of a corneal haze, vitrectomy alone will be difficult. A combination of penetrating keratoplasty may be required. This kind of picture, I don't think any one of us will wait, and we will definitely want to go and clear up the infection from the vitreous cavity. Systemic antibiotics, though EVS did not recommend use of systemic antibiotics, but for cases of endogenous endophthalmitis, severe acute post-operative endophthalmitis, silicone oil fill dyes, these are some of the situations where systemic antibiotics will have a definite role. Endophthalmitis following injections, streptococcus is the most common. It may occur within 3 days or even on the first day, and usually they can be very, very severe, because here you can see how severe these infections can be. And here the inoculum is right into the vitreous cavity. So you may need an early vitrectomy, especially if it's a diabetic patient who has taken intravitreal injection. So to conclude, prompt intravitreal antibiotic injection, even in suspected cases, is most important. Don't wait to use just a trial of corticosteroids. Fast vitrectomy should be considered early on. And once surgery is planned, if safely, you should try and remove as much of vitreous and debris as possible. And meticulous attempts should be done to identify the organism. Though it is challenging and the outcome can be poor, but a case-based approach in every single patient can help improve our results and deal with this dreaded complication. Thank you very much.
Thank you, Dr. Parveen. That was a very excellent introduction to this condition. Should we go ahead with the next talk and then take questions later, Prashant?
Yeah.
Yeah, I think
Yeah,
so. Because,
I think we can have 2-3 talks and then
Yes.
discussion.
Okay.
because
So,
Dr. Parveen has
our,
set the tone for. She's given a fantastic skeleton to the
Fantastic.
talks
Yes.
ahead. So let's
Exactly.
go ahead.
So I think it was quite explanatory. So we'll go ahead with the next talk. I now invite Dr. Sangeet Mittal, who will be telling us about ocular sampling in the case of endophthalmitis. Dr. Sangeet is an excellent vitreoretina surgeon. We've all seen his videos on YouTube, and here he'll be telling us some innovative techniques. Over to you, Dr. Sangeet. He's a vitreoretina consultant at the Thind Eye Hospitals in Jalandhar, with branches in other places in Punjab.
Thank you, Dr. Tinku, and thanks to Team ARC for including me in this webinar. So my topic today is ocular sampling in endophthalmitis, and Dr. Parveen has already introduced the topic very nicely, but just to say that endophthalmitis, a rapid diagnosis and appropriate treatment is required to save the eyes from irreversible blindness, and accurate, appropriate and adequate sampling is the key to precise microbiologic diagnosis. My slides are not moving.
No, not moving.
Yeah.
Yeah.
Now it's fine. So endophthalmitis may be due to bacteria, viruses, fungi, acanthamoeba, or even with biofilms. And why the sampling is significant? Because usually we give intravitreal vancomycin, ceftazidime, and dexamethasone as a blanket treatment in endophthalmitis, but 5.2% cases have vancomycin-resistant bacteria, and there is an increased tendency of fungal infections these days. So sampling is quite important, and so which materials we need to be sampled can be sampled. We can sample the aqueous by doing an aqueous tap, the vitreous by a vitreous tap or vitreous biopsy, and we can sample the vitrectomy fluid. So I'll be showing some techniques of how to do these samples. So first is the aqueous sample. The standard technique is like using a 26 gauge needle, which is mounted on a tuberculin syringe, and then this needle is introduced into the anterior chamber, and the plunger is withdrawn and the sample is collected into the needle, into the syringe. And then this sample is sent for microbiology. The problem is, like in this, you need an assistant to hold the eye, and you have to use both your hands while withdrawing the sample. And most of the times an adequate sample is not obtained with this technique. So I'll just present a small video of one technique that I devised. Using this technique, you can do it single-handedly. So a cut 2cc syringe is attached to a rubber suction bulb, and 26 gauge needle is mounted on this syringe. There's a small hole in the bulb which acts as a safety valve. So you just press the bulb, and you see, and when you release the bulb, you see that the fluid can be aspirated when pressure over the bulb is lifted. So this small device can be used for sampling the aqueous. Seeing live on the eye, you see 23 gauge needle is inserted in the anterior chamber after the vacuum is created. Then the pressure is released as aqueous fluid collects in the syringe. needle is then withdrawn when the fluid is adequate, and this fluid is then sent for microbiology. And this gives us an adequate sample of the fluid which can be obtained. So the advantages of using this technique is that adequate sample is obtained. There is no need of an assistant, and sample can be obtained by comprehensive ophthalmologists also. So this is not like a vitreous sample where you need a retina surgeon and a OT setup to take a vitreous sample. This sample can be taken without delay at the primary center, and positivity is comparable to vitreous biopsy. It can be prepared, this device can be prepared immediately, or it can be pre-prepared and sterilized for later use. So this was an advantage of this device. Coming to the vitreous tap, this is the standard technique of vitreous tap. Though the vitreous tap is not recommended, but where there is no vitreous surgeon, sometimes you have to resort to a vitreous tap. You introduce the 23 or a 24 gauge needle 3 millimeters from the limbus into the vitreous cavity, and you just withdraw the plunger and take the sample. The problem here is that this technique creates a lot of unsafe vitreoretinal traction, because if you pull on the vitreous fibers, you may create retinal breaks, which may lead to retinal detachment in these cases. So it's better to avoid vitreous tap at all costs. The next sample you can take is a vitreous biopsy. So vitreous biopsy is generally done by a VR surgeon in a vitrectomy in a operation theater. So this is my way of taking a vitreous biopsy. You connect a 3-way to your vitrectomy tubing, and this extra port is blocked. Now you introduce your port, like I use 27 gauge cutter. So 3 millimeters from the limbus, and cut and aspirate the vitreous fluid till there is a hypotony, till the cornea dips inside. And when you do this vitrectomy, the fluid comes into the suction tubing. So through this port, you can inject your intravitreal antibiotics, which will form again the pressure, and then this cannula can be removed. Now coming to the sample part, now you just have to open the port here and just take the fluid which is inside the tubing into the syringe. So both sides you can take the sample and you can collect the fluid in it. So this way, again, you can now close the syringe with a sterile cap, or you can directly inoculate onto the media if you have got the media in the operation theater, and then you can send it for the testing. So this is how you can take a vitreous biopsy. Coming to vitrectomy fluid, you can either send your vitrectomy bag, the whole of the bag, for culture where the microbiologist can obtain a good sample. But again, we use bags multiple times, and so the vitrectomy sample may not be reliable in those cases. So again, you can do a very small hack to your technique. Here I'm using a sterilized Ringer's lactate bottle, and you just introduce your IV set. This is again sterilized into the bottle. And now the other end of the IV set is now connected to your cassette. Again, when you are doing vitrectomy, the vitrectomy fluid collects into this bottle.
1 minute left.
Yeah, and you can later on, after completing the vitrectomy, you can just send this whole bottle to the microbiologist who can take a sample from there. So you can, the investigations primarily required are the gram stain, the KOH, the bacterial culture sensitivity, and the fungal culture sensitivity. And the various the comparison of sampling materials this has already been described, that vitreous fluid and the vitreous tap and the vitrectomy are more sensitive as compared to the aqueous fluid. So the take-home message is that vitreous fluid is the best sample for culture in clinically diagnosed endophthalmitis cases, and gram stain or KOH are beneficial investigations which provide results within no time. Thank you.
Thank you, Dr. Sangeet. Well, just one quick question to the chairpersons. Just for the general ophthalmologist, I've been asked this question. Whenever there's a case of endophthalmitis, should an ophthalmologist take a sample from just the vitreous or also from the anterior chamber? Dr. Sangeet, you can take that.
Till then,
I
we
think
can
for a
ask someone
general
to share the presentation. That
For a general ophthalmologist, the aqueous sample, I think should do it. Vitreous sample has to be taken by a VR surgeon in an operation theater. It can't be taken in a clinic or
Okay.
I would not advise anybody pulling the vitreous at all.
Yeah.
Because unless you are a vitreous.
Exactly.
So
Especially in the-
for an ophthalmologist who encounters ENDOPH, it's just anterior chamber tap,
yes,
also vitreous tap.
anterior chamber tap and intravitreal injection.
Okay. That's a clear-cut message. Do all the chairpersons agree with that?
Yeah,
Yes.
I'll just add there, if the general ophthalmologist knows how to give an intravitreal injection of antibiotics, then it becomes easy because the aqueous tap can be taken where the eye becomes hypotonous, and then he can give the intravitreal injection of antibiotics. So
Mhm.
that could be the best approach for a general ophthalmologist.
Okay.
I think we can request next speaker to mount the thing presentation. Meanwhile, there is a chat box. There is a question from Dr. Vikas Gupta. Saurabh, you can load your presentation. What is the drug of choice for pseudomonas? Should steroids be given intravitreally in endophthalmitis? Latest drugs in the treatment by Dr. Vikas Gupta from Haryana. I think we can subsequently answer this part during
Yeah.
the.
So, our next speaker is Dr. Saurabh Luthra, who will be talking on intravitreal antibiotics, the choice, timing, and technique. And after this, we'll have Dr. Lalit Verma, since he requested that he has to leave only. First, we'll have Dr. Saurabh Luthra. Oh. Is Dr. Saurabh loaded his talk?
लगा देता हूँ लेकिन ये फर्क पड़ेगा ही नहीं 100% नहीं पड़ेगा बाकी सबकी आवाज सुपर क्लियर आ रही है
Can you see my slides?
No, we can't.
No, not at all.
No.
Sir, you need to share the screen.
No, I've already shared the screen. Okay, I'll just stop sharing and
Just reopen the presentation and then share.
Yes,
Yeah.
now we can see.
okay. 1 second.
So Dr. Saurabh Luthra is the Director-in-Chief of the Vitreoretinal and the Uveitis Services at the Drishti Eye Institute in Dehradun. And over to him, he'll be talking to us about intravitreal injections.
Thank you, Team ARC, Dr. Prashant and Dr. Tinku for this invitation. And I'll be speaking on intravitreal injections. And my previous speakers have made my job easier. So what are the indications for intravitreal injection? Any case where there's a clinical suspicion of endophthalmitis, where vision is more than hand motions, VR facilities are not available in the vicinity, so just for buying time, or at the completion of vitrectomy. So they are the mainstay of the management strategy initially, as systemic antibiotics do not reach the intravitreal pathogens in sufficient concentration because of the blood-retinal barrier, and intravitreal injections bypass this barrier to achieve therapeutic concentration. What is an ideal agent for injection? It is effective against the offending organisms. It is non-toxic to retina in bactericidal doses. It has an appropriate half-life within the vitreous. It should be injected prior to irreversible damage, and it should be easily available and cost-effective. So these are some of the recommended intravitreal drugs with their dosages: cefazolin, vancomycin, gentamicin, amikacin, ceftazidime, dexamethasone, and for fungal, we have amphotericin and voriconazole. These are the classical agents which we use. Commonly for gram-positive organisms, the first-line intravitreal agents are ceftazidime and vancomycin. For gram-negative organisms, it's amikacin with ceftazidime. And for fungal ENDOPH, it is either amphotericin B or voriconazole. So this is a handy chart which is available and which should be kept in the OR and in the OPD for ready access to how to make the drugs. Also, this is a useful e-kit available from Orolab, which should be stocked in the pharmacy, which has a ready-made supply of all these essential drugs for injection. So how do we prepare this injection? I will show you a video, so I won't go into the details of this. Basically, it involves making the solution, stock solution, and then diluting it with the distilled water. I'll show you a video for all this. So what are the principles of intravitreal injection? The surgeon injecting must prepare the solution himself with a printed reference paper, taking aseptic precautions. It can be done in the OPD or preferentially in a minor OT setup. Informed consent should be taken. One should look at wound integrity, and also if there's any suture abscess, IOP should also be looked into. Prepare the solution for injection in 3 separate tuberculin syringes with 26 and 30 gauge needles. Use topical anesthetic drops and apply povidone iodine and drape with an eye towel and use a lid speculum. An AC tap or vitreous tap, as Dr. Sangeet showed, can be done. The site of injection, which is preferable, is the infratemporal quadrant, 3 millimeters from the limbus in phakics and pseudophakics, and 3.5 millimeter in phakic individuals. Stabilize with a cotton tipped applicator, and then send the sample for direct smear in cytology, gram stain, bacterial culture in sensitivity, and KOH preparation for fungus. Entry is with a 30 gauge needle through the pars plana to reach the mid-vitreous cavity. Bevel of the needle should be pointing away from the macula or facing anteriorly. The injection of the antibiotic should be drop by drop. Second injection should be injected with a different syringe so as not to cause mixing of the drugs and any kind of interaction. An AC wash can be done to decrease the toxic load. The section can be reinforced if there is leakage, and IOP should always be monitored. So this is a short video of how these drugs should be prepared. So this is vancomycin, 1 milligram in 0.1 ml. So the stock solution is 500 milligrams. And in this, we take 5 ml of sterile water. And once this stock is ready, then we will just, so first we dissolve it in 5 ml. So this is the stock solution. And we must give adequate time with gentle shaking of the vial so that the powder is all dissolved. Then we take 0.1 ml of this solution in a tuberculin syringe. So it makes, 10 milligrams in 0.1 ml. And then we dilute it up to 1 ml of distilled water. So you can see that the assistant is gently pinching, the distilled water vial so that, no air enters. And then we intentionally take a small air bubble. And as you can see, as the air bubble travels, it mixes the drug. And then we discard the rest and just keep 0.01 ml for injection. This is ceftazidime, which is 1000 milligram vial. And this is dexamethasone 4 milligram. So we take 4 ml of sterile water and make the stock solution of ceftazidime to achieve a concentration of 250 milligrams. And then we take 0.09 ml of this solution in a tuberculin syringe, which means we have 22.5 milligrams. And then we dilute it with dexamethasone up to 1 ml. And here we achieve the concentration. And again, after mixing well with an air bubble, we discard the rest and take 0.1 ml of the solution for injection. Of course, in fungal, we will not dilute it with dexamethasone. We will do it with distilled water. And so this was about the preparation of the intravitreal injections. So you can see what kind of response we get after intravitreal injection of intracameral and intravitreal injection, and AC wash was done in this case. And you can see good resolution. And at 4 months, you can see complete resolution. So how do we see improvement is there? That there's an increase in vision, however small it may appear. There may be decrease or disappearance of hypopyon, clearing of the AC, consolidation of fibrin and exudates, or shrinking of a pupillary membrane if it's there. The red reflex is better seen. Decrease in pain and lid edema and chemosis are also signs which show that the intravitreal injection is working. So this is another case. After 2 days, vision improved to 618, and at 1 week, it is 6.6. Again, another case of endophthalmitis with a hypopyon, and this is 8 weeks post intravitreal injection. So these are some of the newer intravitreal antibiotics which nowadays we use, like meropenem and imipenem, tazobactam, ciprofloxacin, linezolid, cefuroxime, and trofloxacin. But The next speaker, Dr. Ashish Lal, will be covering these in more detail. So the take-home message is that timely diagnosis and treatment of post-op endophthalmitis can save most eyes. Endophthalmitis once suspected, the cataract surgeon should start patient on conservative treatment with intravit antibiotics and refer to the friendly via surgeon for further management. Thank you.
Thank you, Dr. Luthra, for that very concise and very informative talk. I'll request the next speaker. There's a slight change in schedule. Dr. Lalit Verma, sir, would you like to present before?
Yeah, I am.
The next, okay. So we have with us Dr. Lalit Verma, who will be presenting his talk on the surgical management of endophthalmitis. Well, he needs no introduction. It's our good fortune to have him with us today. He's been the past president of AIOS. He's the immediate past president. He's the honorary secretary general of the South Asian Academy of Ophthalmology. He's the director of the retina services at the Center for Sight, New Delhi. And he'll be talking to us about the surgical management of endophthalmitis.
Thanks, Tinku, for having me here, and congratulations to the entire team of ARC for starting with a topic which I think all ophthalmologists need to be aware. You see what Saurav presented, all ophthalmologists are not so lucky as Saurav, and all patients are not so lucky as Saurav's patient. There are, situations where we have to resort to surgery about this endophthalmitis. And surgery has been likened to a IND kind of procedure that you take out the debulk the vitreous. You see, all of us want to see this, but as has been told by everybody, this disaster can happen. And believe me, this brings a reverse, mood off. Actually, smile goes away. In fact, the entire family. In fact, if I have ever faced endophthalmitis in my own patient, for weeks and weeks, your mood is off. And this happens to a surgeon who operates. People who don't operate in any case have a cushy time always. You see, although all this has been stressed by everybody, end-off still occurs and still bothers everybody. I would reiterate what Saurav said. Intravitreal antibiotics is the mainstay and should be known to each and every ophthalmologist, because this is one thing which can save or mar the eye. This has to be given irrespective of the severity of endophthalmitis, and all patients of endophthalmitis should be given and tried. And if you are lucky, if organisms are sensitive, response is pretty good, as Saurav showed two wonderful examples. This is one of my patient also who recovered good, but believe me, all patients do not recover such kind of. There are indications where we have to go inside, and these have been summarized before also, that patients who do not respond to one injection. Today, my threshold is very less, that I go in for MIVS very fast. I do not keep repeating injections in these patients unless the culture sensitivity report shows that this is a resistant organism. Then severe patients who have very poor vision, you start discussing with the patient that you will require vitrectomy. Then very virulent patients who present on day one, although fusarium also can present on day one. And other things, blood-related endophthalmitis and fungus, they generally we end up doing vitrectomy, because even though voriconazole and amphotericin B are there, the response is not as great as in bacterial endophthalmitis. And once the organisms are, once the exudates on ultrasound show till the retinal surface, as Dr. Praveen Sen had shown one example. So such patients who have very severe infection, they end up undergoing vitrectomy. Also, a lot of these patients are post-traumatic bacillus serous, they require vitrectomy, fungal etiology, and a lot of these patients have chronic endophthalmitis who have recurrent infections despite all the treatment, like something like P. acne, end up doing vitrectomy. And obviously, if you have associated problems like foreign body or detachment in trauma, then you have to subject this patient for vitrectomy. And there is one debate I saw, Tinku, there about the core vitrectomy and radical. To my thinking, there's no debate about that. Once you are inside the vitreous cavity, there's no reason that you do half-hearted job of core vitrectomy. You have to go, you do a radical vitrectomy in this MIVS era, not only in severe, but any case of vitrectomy, and try to peel off hyaloid if there are exudates under the hyaloid. Don't be afraid of, peeling off hyaloid. People say this retina is ischemic and may get damaged. Believe me, those are pardonable things compared to leaving infection inside the eye. So before you enter the vitreous cavity, first and foremost thing always is to clear the anterior chamber. Because if you don't do that, if anterior chamber is not good, then you do a messy job in the vitreous cavity. So this video shows, AC maintainer being put, and then you make a stab in CN to protect the endothelium and remove this fibrinous membrane for an infective membrane of the surface of iris as well as IUL. If you don't do that, believe me, you can't do a very good job because you can't see. Vitreous surgery is very specific. You have to see what you are cutting. If you don't see, you will not do a good job. Similarly, in this patient, what is being shown here is, you see this has a very severe infection. This patient did not respond to intravitreal and 25 gauge vitrectomy we took. And the first job was to clear the anterior chamber. Has to, you have to make the stab incision, inject some visco to protect the endothelium, and then remove this dense fibrinous membrane over the surface of IUL. And once you have done that, then only you should have guts to go inside. Otherwise, you will do a very, very incomplete job. So sometimes you are not able to enter the anterior chamber because the infection is very, very severe. Chamber is flat and there is ectatic wound here, like as I shown here. Also, you should always have 6 mm cannula available. Or if you don't have, then enter directly. Don't make a step, 2-step or 3-step incision. Enter straight into the vitreous cavity because choroid is thick and boggy. And then what I sometimes do is go from the pars plana area and make a dent and make a iridotomy there. And because you are not able to enter the anterior chamber from the limbus route, so you go to the anterior chamber from the pars plana route through the iridotomy and remove all this muck from the anterior chamber. And once you have done so, then you enter the vitreous cavity and then you do a definitive job. So these are a couple of patients where you have done this radical kind of vitrectomy and have had, reasonably okay result. This is a gram-negative Klebsiella. So this was one patient who had a corneal abscess. And then this was a lady from Uttar Pradesh who had come pretty late. You had a corneal abscess, there is a hypopyon, and we go straight inside. As I told, first step, stab incision, take something for sampling, as was shown very nicely by Sangeet, and then try to remove this fibrinous membrane on the surface of IUL. In this particular patient, you see, once I was, peeling this membrane of the surface of IUL, this IUL got mobilized and had to remove this IUL. And a lot of these patients were severe endophthalmitis. You may ultimately end up removing the IUL. And this then was the aphakic area. And you become bold, suture the wound, remove every bit of the muck here. Also, don't forget to remove this connections between the abscess and the intraocular cavity. And after, a long battle, fortunately, we had this good response in this patient. This was the result. At 4 weeks, the abscess became a vascular opacity. Fungal endophthalmitis, although I said the voriconazole, amphotericin B are there, but a lot of these patients have multiple kind of vitrectomies. This patient had, at least 3 vitrectomies before he came. So what we saw was under the hyaloid, there were, collections of exudates. So only thing we did in this 5th vitrectomy here was to remove this hyaloid membrane with the help of backflush needle. And as you see, this membrane was removed. And then this patient had a long-term permanent kind of remission. This is a couple of pre and post patients of endophthalmitis with silicone oil and then after SOR removal. Chronic endophthalmitis, as was hinted before, there are 3 kinds of presentation where we can succeed either with in the bag injection. Remember, in P. acne, the organism is lurking in the bag. So you have to give in the bag injection, not a conventional intravitreal injection. And sometimes you have to do a capsulectomy so as to facilitate the entry of vancomycin in the bag. This was one patient who responded to in the bag injection. This was another patient of chronic endophthalmitis where we had to do vitrectomy, but we saved the IUL and we gave in the bag. However, this patient who had similar kind of presentation, we ended up removing the IUL. So P. acne sometimes may necessitate, removal of the IUL, as is being shown in this picture. You mobilize the IUL, and once the IUL has been taken out, as is shown here, you have to remove all this bag material, with the help of suction, active suction, remove all this bag because this is where the organisms are there. As was being told by Dr. Praveen Sen, this is becoming very common, even though 30 gauge needle is there. Believe me, any 30 gauge needle also can cause infection. Avastin or even Ozudrex can lead to infection if you do not follow precautions or if you do not follow a protocol of sterilizing. Corneal involvement is a bad sign, and you have to take help from your cornea colleague. You would ultimately end up doing, keratoprosthesis, temporary keratoprosthesis with the help of cornea colleague. And once this whole melt is taken away, then you, put in this trocar cannula and remove this infective material inside the vitreous cavity. And ultimately, after this vitrectomy has been done, then the corneal surgeon comes back and puts in the button here, as is being shown here. So this combination of radical vitrectomy, which I say, along with silicone oil, has really helped me a lot, and not only anatomically saving these eyes, and I do not believe in core vitrectomy at all. And this is how surgery, sometimes can bring smile back, not only on the face of the patient, but also on the face of surgeon. So in patients of severe endophthalmitis, this combination of radical vitrectomy and silicone oil has because the reason is silicone oil compartmentalizes and into anterior and posterior segment. The anterior segment can be taken care of by topical therapy by what corneal surgeons have taught her, considered cefazolin, considered tobacin, and Vigamox, eye drop plus cycloplegics. The vitreous cavity is any case filled with silicone, which is impermeable to any kind of organism. And the residual behind the silicone oil can be taken care of by the systemic drugs. So thank you very much, Team ARC, for this opportunity. Thanks a lot.
Thank you, sir.
Thank you, sir, for that excellent talk. Just a question. In the meantime, I'll request the next speaker, Dr. Ashish Lal, to kindly load his presentation. So you mentioned that you would like to use silicone oil in every case where you've done a radical vitrectomy. Is that the protocol that you follow every time?
If I see exudates which are extending till the retinal surface, and if they are touching the ciliary body area, then I will definitely. If it's a mild endophthalmitis where I can see the retinal surface in 10-15 minutes, I will not. But only severe endophthalmitis, my definition is exudates till the ora serrata or till the retinal surface and vision of PL plus minus.
Dr. Shobhit Chawla, would you like to add something to that, or do you have a different approach to this when you do a vitrectomy?
In my use of silicone oil, where I'm confident that I've been able to do a good job and I've been able to remove the hyaloid, and I find that the retina is not that unhealthy looking. Even if I've left a thin skirt of vitreous at the periphery, I might refrain from silicone oil. But if it's a high risk eye, like Lalit pointed, I wouldn't mind putting in silicone oil for 2 to 2.5 months while the eye recovers, and then.
And how do you titrate the dose of the intravitreal injections when you putting it in a silicone filled eye? Would you give half the dose?
I first give the intravitreal injection in a air filled eye, and I don't titrate because I don't think we are already using such a low dose, and then just go ahead with.
I don't think so that antibiotics need to be, diluted. Believe me, these are not toxic doses. We are not using amikacin. If amikacin is being used, then I may agree with you.
I hardly use amikacin.
Yeah, if aminoglycosides are not being used, there's enough margin in vancomycin and ceftazidime to you can give it.
And even using from the meropenem group, there is no harm. You don't need to titrate the dose.
So that's a very clear-cut message for the audience. In a vitrectomized eye, we don't actually need to dilute the or give half the dose of the intravitreal agents. Though theoretically, it has been said, but practically, we see that these drugs are extremely safe for the retina, even in higher concentrations. Thank you, sirs. So now we move on to the next talk. It's by Dr. Ashish Lal, an extremely innovative surgeon. He has a very innovative approach to managing endophthalmitis with newer antibiotics. Dr. Lal is the director and a senior vitreoretinal consultant at the Lal 2020 Eye Care Hospitals in Gurgaon. And he'll be telling us about newer antibiotic agents for super virulent organisms. Over to him, Dr. Ashish.
Hello, can you see the screen?
No.
I think your sharing is stopped. You can reshare. Wait. I'll just... Can you see the screen? Hello?
No,
yeah,
no.
It's coming up. It's coming up as of now. No. Yeah, now it's.
Yes.
The screen share is. Can it be seen?
Yes.
Yes.
Can it be seen? Should I start?
Make it in a presenter's mode, complete.
Okay. Can you see that?
No.
Hello?
So in the meantime, should we take a question while he's loading his talk? A case of recurrent.
I think there is a network issue also at your end.
Yeah, so we have a question in the chat box. A case of recurrent endogenous endophthalmitis, even after vitrectomy and silicone oil injection, how to manage such a case?
Dr. Preetham, you can address.
Yeah, Dr. Preetham Samant, can you please take that question? Request you to.
Yeah, so with already vitrectomy done and silicone oil in place, if the endophthalmitis is still fulminating, I would probably think about removing the oil, doing a vitreous lavage, injecting the antibiotics again, and re-injecting the silicone oil, probably using a heavy silicone oil. What I would do is keep a little underfill of the oil so that it would give me space to repeat my intravitreal injection of antibiotics. Probably also add some higher systemic antibiotics, and also look at systemically where the investigate systemically to look at where the focus of the endogenous endophthalmitis is originating from. This is all that comes to my mind.
Yes, thank you.
Hello, can you see? Can you
Yes.
see the screen right now? Okay. So, good evening, everyone. I feel that endophthalmitis is like a war, and it is a war between the surgeon and the organism. Now, what happens in this war is that you have to have the right mindset of the war. The enemy has entered our territory. A surgical strike is needed. We have to be more aggressive than the enemy. We need to use the right weapon and the right missile, and also protect ourselves during the fight. Most importantly, if our missile is not working, then what next and which one? So here our intelligence, our FBI, that is our microbiology, comes to our rescue. Can you hear me?
Yes, yes.
Hello,
please
can
go.
everybody
We can hear you. We can hear you.
So this is I'm just going to present a few cases. This was a case 12 years back in 2011, where the patient underwent Avastin, had an ENDOPH. I had given vancomycin and tazobactam. This was 24 hours post-vitrectomy. The patient was not responding. Then I again gave vancomycin and amikacin. The patient still did not respond. There was hypopion. The patient became hostile. He went for second opinion to Dr. Lalit Verma and Dr. Shroff. It was then managed by Dr. Shroff. They did a vitrectomy, added voriconazole. There was no improvement. They sent the patient for a PCR. The septicemia panel showed Bacteroides fragilis. So then imipenem was given, and the hypopion disappeared, but we lost the eye. Now we fight to win because there are no runners up in this war, and this is actually true with endophthalmitis. So from 2011 to 2016, I was quite happy. I was using tazobactam, imipenem, and vancomycin at times, and I was getting very good results. And then a shocker came in 2016. I took it lightly because I thought I have good antibiotics by my side. This was the first day. The hypopion was increasing. I could not, I gave vitrectomy with imipenem. Then this is second post-vitrectomy. Now here again, after a few days, then I took up vitrectomy, gave amikacin, voriconazole, and linezolid, sent the patient for PCR. Now the PCR showed Pseudomonas aeruginosa. Now, I did not have any other antibiotic with me. I asked my Exciton guy that what can we do? He said you can get an antibiotic resistant marker done. So that was done, and which showed that the Pseudomonas was resistant to carbapenem. Now what next? This guy told me that people are using colistin, and here then I saw this article from Dr. Samant, I think he's here, and I gave the patient colistin. The eye responded, but we lost the eye. So in these two patients, we could actually kill the organism, but we lost the eye. Now I was more prepared to handle endophthalmitis. Now these two patients, husband and wife, operated somewhere, and they said to me that the surgeon had given vancomycin. The husband was not responding. So what next to do? For gram positive, usually vancomycin works most of the times. For gram negative, Amica did not work. So what do I have? My friend was in despair. I wanted to get out of this mess and we wanted to win this war. So what I did was I did a vitrectomy, vitreous tap, and gave vancomycin, and I gave all these three. Now this is a very radical approach, but I gave these three. This is case 1 and this is case number 2. Both of them responded well, and the patient came to the microbiome came out to be Pseudomonas aeruginosa. Now look at this. At 48 hours, you have the sensitivity report which says resistant to amikacin, resistant to tazobactam, and resistant to imipenem, but sensitive to colistin. Now, we were lucky we had given this colistin. Now, just imagine 2 more days with Pseudomonas inside our eye. So microbiology showed whatever we did was right. The patient responded. Both the husband and wife, my friend was very happy. Now 2 more cases. Not all organisms are Pseudomonas. This is a 3rd day post-op, case 1 and case 2, done at a similar clinical setting. Now again, I did a good vitrectomy and gave these antibiotics. Now the microbiology here showed streptococci in smear. Now this is a gram-positive diplococci. We had already given vancomycin. I did not wait for the report, gave vancomycin, Vigamox, and Deca. The growth came out to be streptococci. It was sensitive to vancomycin, moxifloxacin, cefazolin. We had already
I think we have lost Dr. Tinku.
Yeah, I think he's lost connection. In any case, I think we saw his approach to managing ENDOPH with the newer age antibiotics. So, Dr. Ashish, would you like to connect again?
have I connected? Okay. Is it connected?
Yes.
Yes.
Yeah. So in this patient, what I did was
video. Dr. Ashish, you switch off your video so that your connectivity will be better.
okay. Okay, I'll do that. This one. This stop. Okay. Okay. So now in this patient, I did an IOL explantation with repeat intravitreal antibiotics. So I would say here again, the war principle works. If we don't end war, war will end us. And you can see. So these are the 2 patients. They responded well. One was perfectly okay. The other, the cornea was bad, but we could save the eye. So I would like to say that not all virulent are Pseudomonas. Super virulent bacteria like streptococci need to be more aggressive. IOL explantation and maybe approach like silicone oil. In short, we have to kill the bug. That is the most important. Gram-positive vanco works almost all the time, except at times when there is antibiotic or an MRSA where we can give linezolid. In gram-negative, 80 to 90% cephta and amikacin are effective. Otherwise, tazobactam, imipenem, and colistin can be used. So finally, I would say what is essential in war is victory, not prolonged operations. So we have to be very clear as to what we are dealing and how we need to kill the organism. Thank you.
Thank you so much. And thank you for giving us an insight into the use of these new antibiotics. I'll just like to ask the chairpersons that, like in my practice, I have now switched on to from vanco. Vanco and imipenem is my drug of choice. I have done away with ceftazidime. So is there any other, or is the first injection that you give vanco plus ceftazidime, or do you also give these newer antibiotics? Dr. Shobhit, sir?
Imipenem along with vanco, and if I feel the need, I add ceftazidime with it. But I do use dexamethasone always because I feel steroid is the most important in such an inflamed eye to prevent collateral damage.
Very true. So, Dr. Preetam Samant, your take on this?
You know, when we are dealing with Pseudomonas, you know, we are like Dr. Ashish said, it's literally a war.
Yeah.
Because from the virulence point of view, this organism is secreting lysosomal enzymes, which actually melt the tissue. That's why you see these corneal ring infiltrates, and you literally have the cornea melting within a couple of hours or in a day or two. That is the virulence aspect of this organism. As far as its sensitivity is concerned, this organism, has a peculiar cell wall. So our routine antibiotics like Vanco and ceftazidime is not able to penetrate it. What these newer antibiotics do, like meropenem and colistin group of drug, it attacks the cell wall of the organism. So actually, it enables probably your Vanco and your Cefta to start penetrating into the organism. So that's why in Ashish's case, why the cocktail started working is when the colistin and imipenem made the organism cell wall weak, your Vanco and Cefta started working on the organism. So like Dr. Shobit said, if you have your routine drugs or cocktails not acting, not giving you the result, then you should not waste any time and switch over to these higher antibiotics. You need not only go with, like a monotherapy of meropenem or colistin. You can cocktail it with Vanco. Like Dr. Tinku, you said, right? You use Vanco with imipenem. So that would work synergistically for a bug like Pseudomonas.
Thank you so much. Dr. Srinivas, would you like to add something to that? Or we go on to the next talk? So the next talk, we have Dr. Rohini Grover, and she'll be presenting some interesting cases of endophthalmitis. She's called them scary scenarios in endophthalmitis. Dr. Rohini is a vitreoretina consultant at the Healing Touch Super Specialty Eye Care in New Delhi. And over to you, Dr. Rohini. Looking forward to your cases.
Thank you, ma'am, and thank you, Team ARC. And today's cases from my side are scary scenario, both for the doctor and the patient. So coming to my first case. Wait. Is it visible?
Yes.
Okay. So the first picture is also very scary, and the patient underwent therapeutic keratoplasty. So this is my first case in which a patient underwent cataract surgery. As we have already discussed, that after cataract is the most common cause of exogenous endophthalmitis. And this patient presented just 1 day history of PLPR inaccurate and presented it evening as the hospital was open. We saw him in the evening and there was hypopyon, lid edema, ciliary congestion. So immediately an ultrasound was done and the intravitreal injection was given the same day. And as ultrasound, we can see there are clumps, vitreous membranes and vit echos. And same day we gave the empirical therapy, as we have already discussed that early. This is the typical practice that we give the empirical intravitreal injections and then start our routine medicines, that is tablet moxifloxacin has taken over ciprofloxacin over the years, and we start with the antibiotic therapy. And since this was the case from institute, the culture was sent very fast and the KOH revealed no fungal elements. But whenever gram stain used to come like plenty of polymorphs, we start suspecting that something will be like the culture won't come negative. It will come with some growth. So by morning itself, it was Pseudomonas aeruginosa. And as we have already discussed with the previous cases, that now these days we are seeing a lot of resistance to the common antibiotics, which we were giving earlier. So here the organism was sensitive only to colistin and imipenem. So the same day we gave the injection, and this time imipenem and dexamethasone was combined. And also second day, then again the injection was repeated. So once the disease was under control, there was no hypopyon, ciliary congestion has gone, and even as per the grading, we could see the second order vessels on fundus examination. We thought that the patient can now be taken for pars plana vitrectomy. So as the patient was getting disturbed by the floaters. So on ultrasound, we always used to see that PVD has been completed. Why? Because we wanted our surgical success. So once the PVD was completed, the pars plana vitrectomy was done and a repeat antibiotic injection was given. This is this case 2, and this is this is on presentation. Since it was a Pseudomonas patient, the PR was inaccurate. He came with hypopion, but 1 month later there was no hypopion, and the vitreous cavity was also clear. So we were lucky in this case, as the diagnosis was made faster and the right antibiotic was given. And we also found that most of the antibiotics were resistant. So we also did a retrospective studies, thinking that what is the past 2 years data which is coming to our center. So we found that there were higher resistance was increasing in the higher end antibiotics. There has been literature that the empirical treatment is now getting resistant to the antibiotics, but here we can see that with linezolid, imipenem, even with the higher drug antibiotic, the resistance is increasing. The only thing which we found was there was no case which showed colistin resistance. So this was the scenario that ceftazidime, as Tinku ma'am pointed, that she's not giving ceftazidime as a choice because she's combining vancomycin with imipenem. That is because the more of the resistance is coming with ceftazidime. But again, we are still lucky that we have a good sensitivity with vancomycin, and it has been studied over previous 2 decades that vancomycin sensitivity is still persisting, though the MIC has been increasing now. And linezolid and piperacillin and imipenem, these are were the higher end antibiotics which were quite sensitive, but now we can see their resistance is also increasing. So this is about case 2, in which one of our patient, he reported after a self-sealing open globe injury, and we could see the foreign body, advised the patient immediate surgery. And there was also on the day of presentation, there were pre-retinal vitreous infiltrates, but the patient lost to follow-up, and patient didn't even get a ultrasound done. So this patient came after 3 days. And when the patient came, now there was a traumatic endophthalmitis with hypopion and exudates in the AC. So this patient was immediately taken for vitrectomy. There was a foreign body inside. On B scan, it was visible. And vancomycin, ceftazidime, and dexamethasone was given. And the organism was Staphylococcus. Staphylococcus is very commonly seen in traumatic endophthalmitis and also Bacillus cereus. So even we suspect fungal too, but here we gave on the first day itself, we gave dexamethasone and started oral steroids early, because as Shobit sir has pointed, that steroids have a role and for controlling the inflammation, which is much more in traumatic endophthalmitis. Luckily, this patient was sensitive to many drugs, like you can see vancomycin, linezolid. So we switched the patient to oral linezolid, and also repeated our intravitreal injection and gave vancomycin and dexa. So again, 12th post-op day, post-vitrectomy, IOAB was repeated. Same vanco and deca. Sometimes even after vitrectomy, we have to keep a track on these patients. Although we start oral antibiotics and topical fortified eye drops, still there is some signs of inflammation which keep coming. So we can repeat our intravitreal antibiotic. And this was the foreign body. This you can see it on the B scan. There's an iron foreign body which was removed. And after the removal, the eye looked quite and there was no hypopion. This is 1.5 months later after vitrectomy. And the patient was not having a good vision because the patient didn't go for an early surgery. If had the patient underwent early surgery, in such cases, traumatic endophthalmitis could have been avoided and the visual acuity would have been good. Coming to our third case, which is very interesting. This patient underwent vitrectomy for retinal detachment, and the lady was pseudophakic. And after 37th day post-op, the visual acuity improved in 2 weeks to 6/18. Patient was doing fine, but on nearly 40th day, patient came back with hand movements, history of pain and swelling. There were KPs, there were fibrin reaction in the anterior chamber. And on fundus examination, under the oil, we could see fluffy growth and also on the posterior pole and in periphery. So these infiltrates was seen, and immediately systemic workup was also done, because thinking to rule out endogenous endophthalmitis, but this patient was taken for immediate silicone oil removal, and the vitreous and exudates were sent for sampling. So the oil was taken, and also those fluffy deposits were held with end grasping and sent for culture. So the same day, in under air, a vitreous lavage was done, and with vancomycin, cephta, and amphotericin B. Since this is a chronic endophthalmitis, we were suspecting a fungal. So amphotericin B was given on the same day itself. Now, this patient, after silicone oil removal, the growth didn't come early in this case. So we repeated another vancomycin, ceftazidime, and amphotericin. And on culture report, we found that under silicone oil, there was Aspergillus species. And in the vitreous tap, that those fluffy deposits, that were atypical mycobacterium. So we also, this was the fungal septae, which is Aspergillus, and this is atypical mycobacterium. So the switch was made, the voriconazole and amphotericin were given. Here, the point to be noted is that once you are having a fungal endophthalmitis, both voriconazole and amphotericin work better, because these are all fungicidals. So to have a good fungicidal effect, they have to be repeated quite early. Otherwise they don't get a cidal effect. So a repeat voriconazole and imipenem and amphotericin was given, and 3 injections of voriconazole and amphotericin B were repeated along with imipenem.
Dr.
So this was the whole.
Wind it up. We are running.
So this was the timeline, and so to summarize, this is another patient which trabeculectomy was done, but this patient responding to intravitreal. So to summarize, drug resistance with empirical is higher end antibiotics, and judicious use of antibiotic, role of PCR in culture negative growth, prompt vitrectomy in trauma, and also combine intravitreal injection and voriconazole and amphotericin till the resolution of vitreous exudates. Thank you.
Thank you, Dr. Rohini. Scary scenarios, but managed very successfully. Congratulations to you for handling all these cases nicely. Do we have time for a question? So I'd just like to ask the panelists, what is your approach to fungal endophthalmitis? Would you like to start just with voriconazole, ampho, or a cocktail of the 2 drugs together when you suspect fungal endophthalmitis? Dr. Shobhit Chawla, sir?
I mostly use voriconazole alone, and if it doesn't work, then I add amphotericin B. Today, my drug of choice is mostly voriconazole, and it's repeated. It's not one injection, as you know, in any fungal endophthalmitis. Needed vitrectomy and use of silicone.
Dr. Preetam Samant, what is your?
I think I'll echo that. I'll ditto that what Dr. Shobhit said. Nothing more to add there.
Yeah, so the thing to point out in a fungal is that you require repeated injections. The trick is never to give up. You may need multiple injections. Maybe every day you would be injecting such patients of fungal endophthalmitis. It's very recalcitrant, but the trick is not to give up. So with that, I invite our next speaker, Dr. Rajesh Sinha. He'll be speaking to us on the standard pre- and post-operative measures for endophthalmitis. Dr. Sinha, have you loaded this talk?
Yeah.
So Dr. Rajesh Sinha is a professor of ophthalmology, cornea and cataract and refractive surgery services at the Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. And we all have seen him very active in AIOS. So over to him.
Thank you, Dr. Tinku. Thanks, Dr. Prasad and the whole team of ARC. A lot has been discussed about post-operative management of endophthalmitis. So I'll be discussing about the pre-operative and intraoperative measures that are needed to prevent endophthalmitis. So first, pre-operative measures. One important thing, you all are retina surgeons must be discussing so much about the good control of blood sugar to prevent diabetic retinopathy. But there are multiple studies that have shown that uncontrolled diabetes increases the risk of endophthalmitis. And if endophthalmitis has happened, And if the blood sugar is uncontrolled, then it is difficult to manage such cases as well. These are refractory cases and very challenging scenarios. So a good control of blood sugar is very important. Roplast or syringing, that is the gold standard that we have been doing for so long. It has to be ruled out. It has to be done to rule out NLD block. But of course, it should not be done on the day of surgery. And no contact procedure like biometry or tonometry on the day of surgery should be done. If there is, any sign of infection, the patient has come for the surgery to you, and on that day you see that the patient is having congestion and watering and all that, then in that case, one should avoid the surgery and defer it for some time and use antibiotics. Preoperative topical antibiotics has been in use for quite some time now. For a long period, preoperative broad spectrum antibiotic for 3 days was being used. A lot of people have shifted to a 1-day preoperative topical antibiotic. But what is most important, it has not been considered as mandatory, but what is considered mandatory is povidone iodine. That should be put just before the surgery. That is very essential to sterilize the area that is to be operated. And earlier we used to cut the lashes, but now we have good quality drapes which can cover the lashes nicely all around, so you don't have to clip the lashes and just use the drape to cover it. Intraoperative measures are many, which starts from the adequate OT sterilization, like you should have a proper OT design, which has been designed into an outer zone or a mid zone and aseptic zone and a disposal zone. So all these zones, the OT design should be appropriate. Then OT sterilization should be properly done. Spray of bacillocid, 5 minutes. A spray of bacillocid 2% should be used, and the OT should be closed for 6 hours before use. And ultraviolet radiation has been found to be quite effective, and it can be used, but only thing is that there are reports of does have a carcinogenic effect, and there are reports of that. So one has to be careful. It should be switched off 2 hours before entering operation theater. Then, of course, these swabs and the culture should be done from the OT. So it should be taken at least every 2 to 3 months' time. And then moist swabs are taken from microscope and then head end of the table. And then agar plates can be kept open at the head end of the table for 30 minutes. So all these things should be done in order to maintain asepsis. Sterilization of instruments should be proper. Class B autoclaves and ETOs, they should be used. If possible, one can use disposable instruments as much as possible so as to prevent the risk of contamination and infection. Then monitoring of sterilization should be done with one should use chemical indicators. These indicators are quite useful, that give you an idea that the proper sterilization has been done. And as far as the most common surgery, that is cataract surgery or phacoemulsification is concerned, so I just wanted to emphasize that if you are using the phaco tip and sleeves, it should be used in one case and it has to be changed for each case and then re-sterilized. Apart from the instruments and the OT, the surgeon should also maintain a proper sterilization of his hands. So hand washing should be done with betadine or chlorhexidine scrub for 3 minutes. If you are using liquid soap, then 5 minutes. Although a lot of people still are using bar soaps, I've seen in many OTs, but it should be avoided, and we have completely stopped using it. Purified water should be used for scrubbing, and OT etiquettes like do's and don'ts should be put on the wall so that people don't forget it. Proper gowning, sterilized gown should be used. If you have gone out of the OT wearing the gown, you should change it. You should re-scrub. There should be separate slippers, and the same slipper should not be used in the bathroom. Then gloves should be fresh for every case. So all these measures should be taken. Some important do's and don'ts are like a sterilized gown, as I said, is mandatory. And then you should document everything, what has been done. Like everything should be documented, because something which has not been documented is considered not done. So what is most important is proper documenting of all the do's and don'ts that you have been following. And patient hygiene should also be maintained, a proper cleaning of the eye, use povidone iodine, 10% on skin and periorbital area for 3 minutes, or it should be allowed to dry before bringing the patient to the operation theater. The boundary of the area where you should be cleaning is formed by the hairline, so it's on the top, then tip of the nose, so all this area, nasolabial fold and external ear. So this whole area should be cleaned. And once you have cleaned the skin, you should put the 5% povidone iodine in the eye. So this is, again, once you have cleaned the patient outside, once the patient is in on the table, this is the area, as you can see here, the hairline, the tip of the nose, the nasolabial fold and the external ear is the boundary within which you should clean. We should use 10% betadine, and this is a diluted 5% betadine that is being used in the Calde sac, and you put it and then wait for 1 minute, and that is very essential for maintaining complete surface sterilization of the ocular surface wherein you are operating. Again, a lot of reports are there as far as cluster endophthalmitis is concerned, wherein irrigating bottles have been found to be a reason. So you should always check the irrigating bottles manually. You should see whether there's any floaters, etc., in that or not. Then the rule should be that one bottle should be used for one patient, and it should not be continued in the other patient. And you should always note the batch number of all consumables, and if possible, in between, you can send some sample of the irrigating fluid for culture, and that is something which is very helpful. And again, that should be documented. Intracameral antibiotic is now being used very frequently, and it is good. I mean, there are many people who don't use it, but I would say that for safety, as far as litigation is concerned, it is better to use it. And you should use it once you have hydrated the wound. The wound is all sealed. Then you should inject the intracameral antibiotic and try to direct the antibiotic. See, I'm just looking at the globe that it is tight. And now through the side port, I'll enter. So there will be slight egress of fluid. And then you will push the antibiotic into the area of bag, so that the antibiotic remains in that area. So that is important. And wound security should be maintained. It should be a watertight wound. And when there is any doubt, one should not hesitate in putting a suture. So in conclusion, a lot of efforts, a lot of guidelines, a lot of things are being done for preventing endophthalmitis. And yes, the endophthalmitis definitely is on decline. The percentage that we used to have was higher earlier. Now it's less because of so many appropriate measures that we take, preoperative as well as intraoperative, and also the postoperative care. And as I said, fluid is something which is essential. One should keep a watch on it, and adequate sterilization of instruments. And intracameral antibiotics, as I said, is good. I mean, a lot of people are not using it, but for these days, this is the era of litigation, so it's better to put intracameral antibiotics and document it so that you are on the safer side. But the most important is that use of povidone iodine in cul-de-sac. That is the most important thing as far as prevention of endophthalmitis is concerned. So thank you very much for your patient listening, and any suggestion, any point for the experts to make.
Thank you, Rajesh Bhai, for being with us amongst the crowd of all vitreoretinal surgeons and teaching us some basics for the anti-segment surgeons who are also going to watch us. Thank you. We will be having questions subsequently because you have many questions we will ask, but we'll move on to it later part of it.
Okay. So our next speaker is Dr. Gagan Bhatia. He'll be telling us about a series of endogenous endophthalmitis, which was initially diagnosed by him. It's like a conundrum. Dr. Bhatia is a senior vitreoretina consultant at the Shroff Eye Center, New Delhi. And over to you, Dr. Gagan.
Good evening, everybody. And I first of all thank the team ARC and especially Dr. Tinku and Dr. Prashant for this opportunity. I hope I'm clear and the slides are visible.
Yes.
Yeah, thank you. So I think endogenous endophthalmitis is a separate entity altogether, and I think we all saw a big uptick in the cases during COVID, and especially that is what COVID I think taught us to manage endogenous endophthalmitis, which was probably one of the things which was seen in multi-specialty hospitals, but COVID made it enter into every clinic. So, and with that, there were also situations where we had a lot of surprises. So this 65-year-old lady presented 2 weeks after discharge from the ICU, and she was basically being treated as non-infectious uveitis and was on oral and topical steroids. She had an ICU stay for roughly 3 weeks and was on systemic steroids also for more than 7 weeks. The visual acuity was PL, and she presented with a total retinal detachment and an inferior whitish fluffy material with a retinal abscess. So we took her immediately up, suspecting endogenous fungal endoff. We took her up for a vitrectomy. I think after doing a generous vitrectomy, the inferior abscess was kind of localized. The retinotomy was made, and the abscess was kind of debulked as much as possible. There were already membranes which were present, so those were taken off, and also bimanually with the light pipe and also with the forceps, the membranes were teased off. Finally, the case was completed with silicone oil injection and laser. And to our biggest surprise, while we were closing the eye, we saw this white fluffy material, whitish material, which was seen in the I think under the conjunctiva. So the sampling obviously was taken, and which grew Candida albicans, and the retina was well attached. And so we decided to send this whitish material also for histopathology, and it was surprising to see subtenon tricot crystals, which was present in that case. The second case is again a 47-year-old male, which was again being treated as a uveitis for a very long time. Then somebody did diagnose or thought of endophthalmitis, and a vitrectomy was done. And finally, the patient presented to us like this with a history of intravitreal voriconazole given 3 days back. The patient was again taken up for vitrectomy. You can see a large fungal mass over there. And finally, we had to resort to a lensectomy because to take out the fungal abscess. And the whole retina was also studded with this whitish material, which was taken care of. The abscess also had retinal tissue in it. So we kind of did a relaxing retinotomy, had to be resorted to. And finally, the retina was settled with oil. As you can see in the post-operative period, the retina was well attached and the patient improved to around 6/18 vision, but there was scarring at the central area where there was a small abscess present. The next case was a diabetic 50-year-old lady. She presented with 6/12 parts vision, and she was basically referred for an intravitreal anti-VEGF injection. On history, actually, we did an indirect, and on doing an indirect ophthalmoscopy, if you've seen a superior nasal quadrant, there was this whitish, creamy kind of chorioretinal kind of an abscess, which was coming up very small. And on taking history, she again had a ICU stay for a month and was an IV methylpred for around roughly 5 weeks. We again suspected endoff and started on oral and topical voriconazole and kept her under very, very close watch. And we saw the abscess scarring as well as the CME going down. Finally, during the follow-up period, she started with the scarring of the abscess. There were also the fluid which was coming because of traction. So we thought of going in for a vitrectomy, placed a bulb buckle to kind of support that area, and went to relieve the traction around the scarred tissue, and also kind of finally cauterized that abscess and did a retinotomy and finally put silicone oil. She also improved, and in this case, obviously, we had to again resort to a phacoemulsification, but without an IOL. And post SOR, she also improved drastically well. The next case was an extremely interesting case who was diagnosed as neovascular AMD. These were pictures which were taken from the primary person, and there was a heme spot at the posterior pole in the right eye and kind of a exudative kind of a material in the left eye. So it was diagnosed as neovascular AMD. Was thought of giving a anti-VEGF injection, which luckily the patient developed some vitreous exudate, but again then treated as a uveitis with steroids. Finally, he presented to us with counting finger vision in one eye and PLPR in the other eye, and again a history of ICU stay and long-term systemic steroids was there, and there was white fluffy material in both the eyes. The patient was taken for a vitrectomy. We chose to do the right eye first because that had a better prognosis, and an intravitreal antifungal was given in the left eye. The left eye was again taken up for surgery after 3 days, and you could see these very large subretinal abscess mounts, which were cauterized, and to whatever extent we could kind of manage, we did, but decided not to really go after them and injected oil. Finally, in this case also, Candida albicans was the causative organism, and we did lose the left eye after some time. Though the right eye did very well and the vision was 6/12, he was on oral and topical voriconazole for almost 9 months, and there was no problem for 1 year. To our surprise, after almost 9 to 10 months, he came with this very large, fungal ball kind of an abscess in the anterior chamber. And the patient, again, we did a tap, and it again grew Candida albicans. It was surprising because all through he was all well, and probably a case which was absolutely well resolved. To kind of just keep the debate alive, in the later part of the day, I would close this case at this stage and probably have Dr. Shamik and Dr. Darais discuss this. So I think one of the learning points, I would not go into the theory too much because it's already been discussed, but I think one thing was that it was always endogenous ENDOPH has always been taken as a case of immunocompromise. But I think there are various reports which have come during this COVID era where immunocompetent people also can, end up with endogenous endophthalmitis. There are, I think, a few learnings from these cases was that, one of the key diagnostic things is to have this white fluffy infiltrate in the vitreous, originating from the choroid into the retina and into the vitreous is one of the key factors. I think there are studies by Zhuang et al. Where they have done, they've been lucky enough to do OCT scans through these, and you could, a similar picture was also seen in our third case, where exudates which arise from the choroid and into the outer retina involvement is more. You have more scarring, and there are cases which originate in the internal, in the inner retina, and going into the vitreous have a better prognosis. I think the second case also showed this sort of a chorioretinitis where we had a superinasal case, and probably was a chorioretinitis which was picked up earlier, and probably oral voriconazole and our treatment kind of helped the case have better visual outcome. So I think as far as diagnosis is concerned, I think again this has been discussed, but I think one additional point that we learned was beta glucan assay. I think this is a very upcoming, and there are a lot of studies around it. 2 of our cases in these COVID patients, and also there are 2 patients of post cataract surgery chronic endophthalmitis where beta glucan assay have been done, and they have come positive. And this is basically a polysaccharide which is found in the basically found in the cell wall of the fungal, and can kind of help us towards a certain diagnosis. So there are, I think the literature is really heavy on endogenous endophthalmitis, especially after COVID in the last 3 to 4 years. Thank you.
Thank you, Dr. Gagan, for those wonderful cases. The only point of debate is, should we always do a chorioretinectomy for that abscess, or after doing a complete vitrectomy, would we be able to manage by giving intravitreal? We'll debate it later on. Meanwhile, I will request Dr. Vivek to share his presentation, and I will have an opinion from Dr. Shobhit Chawla over the same issue. Till Dr. Vivek Dave is ready.
Thank you,
Well,
Dr.
I have never done. When I've seen an abscess, I've treated it with just intravitreal, but his cases, after seeing his cases, I think in some situations it is justified to go ahead with the chorioretinectomy, especially the case which he showed with an retinal detachment. I think there it was justified.
So I think even there, it was not a complete chorioretinectomy. It was basically a retinectomy.
Yeah,
where they
retinectomy,
cauterize that, cauterize
Yeah.
the abscess more. I think it's very scary because they're usually stuck to the choroid very, majorly, and you can end up with a bleed and.
Okay.
Chorioretinectomy would be more messy, just a simple retinectomy,
Retinectomy.
and letting the drug get access to the
Subretinal space. Fine.
One more thing I would like to add is, in there was a fantastic presentation by the way, Dr. Gagan. In his case, he had a good media. The media was clear. His cornea was clear. So when you're doing these complex vitreoretinal things like retinectomy and laser, for him, I would do the same thing what he did, because the media is clear. But many a times you're dealing with an ENDOPH where the media is not clear, then you don't want to go and do a lot inside and worsen the situation. Then you would rather leave the abscess and hope for it to resolve with your antibiotics and your medical management later on. So in this situation, I would have probably done the same thing he did.
Thank you. Thank you. Now we have Dr. Vivek Dave, who is a consultant vitreoretinal surgeon from LV Prasad Eye Institute, who would be presenting his presentation on the usual, the unusual, and the imposters. Over to you, Vivek.
Thank you, Dr. Bhavan. Thank you, Dr. Bali and team ARC for having me. I hope I am audible clearly and the slides are visible.
Yes.
Yeah, thank you. We have limited time, so I will just go through a few examples and share a few clinical pointers with the audience. I understand a lot of audience would be from general ophthalmology. So I hope that these pointers turn out to be helpful. So the first one is, how do we suspect endophthalmitis? So I would say any unusual inflammation post-surgery increasing pain, post-surgery decreased vision. So while point 2 and point 3 are self-explanatory, I feel point 1 is also pretty crucial. Any unusual inflammation post-surgery. Why I say unusual is because as surgeons, all of us know our skill set. All of us know how we deal with different cases, be it small pupils, be it diabetics, be it ones with hazy cornea, or even a routine surgery. So we all have an idea of what usual post-operative inflammation we expect in our own hands. So whenever you see a post-operative inflammation that is out of proportion to what would otherwise be expected in that particular surgery, then I think possibility of endophthalmitis should be high on your radar. And we will not go into details of management because I think that has been covered as a good overview by Dr. Parveen Sen previously. Importantly, first 2 weeks are pretty crucial, though acute endophthalmitis is defined as endophthalmitis in the first 6 weeks. A lot of cases, a majority of them occur in the first 2 weeks. And these are two tables from the EVS and the ESCRS, which till date are the two biggest studies prospectively done on endophthalmitis. And here you can see the different combinations of symptoms and signs, which ranked very high in their data set. So if you see any of these combinations with, like I said, unusual inflammation post-op, then you should be on your guard that you are possibly facing with an endophthalmitis. Now, let us look at certain deviations. Now, this is a patient who presented with recurrent inflammation, was being treated as a case of uveitis. For her, HLA-B27 was positive and the patient was being given a lot of steroids and rheumatological agents to try and bring that inflammation under control. But the eye inflammation wouldn't settle down. Now, there was a history of cataract surgery, which was a long time ago, I think 1.5 years ago. That's a pretty long time back. If you look at the slit lamp photograph, we don't really see plaques, but we see these small flocculent lesions that were present towards the periphery. Now, this is not what is the classical description of a delayed onset endophthalmitis, but these flocculent sort of deposits were not in sync with a possible PCO or even with a remnant cortical matter from a previous surgery. So from that point of view, this patient was counseled on the lines of delayed onset low-grade endophthalmitis. In my practice, I am a little pro for removing the IOL early, and this patient underwent a complete capsulectomy with an IOL explantation, which was plated on table in the OR. And the next day we saw that we had growth of yeast in that. Further sort of Vitek assessment showed us that it was Staphylococcus cepheri, which was a type of a yeast organism. And down the line, the patient did well with intravitreal amphotericin B and was later posted for a secondary IOL implantation. And down the line, we saw that this entire IOL explantation worked well, and the endophthalmitis settled down. Now we look at a second scenario, day one post cataract surgery. We are seeing a lot of fibrin here. We are also seeing hypopyon. So again, thoughts of endophthalmitis are entertained. But an important observation here it is more whitish than it is yellowish. The fibrin that you're seeing is restricted largely over the pupillary plane, and the B scan was completely normal. Though not clear on the slit lamp photograph, there is conjunctival hemorrhage, but there wasn't any significant chemosis or lid edema. And pain-wise, the patient was largely comfortable. So this was taken as inflammation. The patient was put on steroids, and this is what you see, what is happening serially with the patient. This entire central fibrin and coagulum is sort of contracting on the central visual axis. And this is what we have, months down the line where everything is completely cleared out. So there is this entity described in literature called as a non-infectious endophthalmitis. Classically, if you go ahead and take a sample, the AC type is negative. B scan already looks clear. The AC does look quote unquote hot. And this resolves very well on topical cycloplegics and steroids. The literature mentioned here is a good read and gives a good idea about this condition in general. Now, a different condition, again, operated a day prior. Next day post-op, you see a hypopyon. But note a limbus to limbus corneal edema, lids which are not really inflamed, and the conjunctiva which is pretty quiet. You don't see any sort of chemosis or hot looking eye. Corneal edema very clearly seen on the slit photograph. B scan is clear. So what is this? This is a toxic anterior segment syndrome, or TAS. So TAS, as we know, exquisitely responds to steroids, and this patient was put on hourly steroids. And we will see this is what was the presentation of the patient. And as the patient is put on steroids and cycloplegics, significantly the entire inflammation clears out and the cornea completely clears out. This is what we began with, and this is what we ended with. So cornea to cornea edema, otherwise things look quiet. There may not be a hypopyon. Hypopyon, though significantly seen in endophthalmitis, can also come up in TAS. Last example, whitish reflex in the pupillary margin, cataract surgery done 8 to 10 years ago. Patient has congestion, noted since the last few weeks, mild discomfort in the vision, fluctuating vision, AC otherwise quiet, B scan normal, fundus is visible, seems normal. So the patient in this constellation of symptoms is referred to me as a case of delayed onset low-grade endophthalmitis. But when I saw him, the conjunctival congestion was not suggestive of a ciliary congestion. It was conjunctival congestion, as we read in textbooks. Retracting the lower eyelid showed some sort of exudates or coagulum in the cul-de-sac. So basically, the patient had conjunctivitis with whatever was inside the eye, to which I will come to later. So the conjunctivitis was treated, the redness settled down, and we were left with what is seen right now within the eye. So you can see this whitish material, which actually on the slit you will realize is seen within the capsule. So when I make the patient lie down, this actually spreads out entirely on the posterior lens surface. And as the ASOCT is showing us, the aggregated material was lying behind the intraocular lens. So what were we dealing with here? If you look at the ASOCT, the anterior lens surface and the iris. So this basically was a zipper closure, or what is called as a capsular distension syndrome. So these are remnants of the lens matter which can get caught, and in some cases they may proliferate. And when they proliferate, they aggregate in the capsule. And this was what was possibly erroneously picked up and suspected to be a posterior sort of a hypopyon within the bag. And the patient was deemed to have an endophthalmitis. So it's a rare occurrence after cataract surgery, but it is exquisitely sensitively treated by an Nd:YAG laser capsulotomy. So this is what the eye was post YAG cap. Moment the YAG cap was done, you see that the entire matter is gone. You look at the ASOCT, the entire white thing that you were seeing before is completely cleared out. and the patient has now, come back to a normal sort of a vision, and the eye has quietened down. So in short, facing endophthalmitis or its imposters is inevitable. So I have tried to sort of make this a little fancy, but I think these are important terms. You require to document, you should be able to differentiate, you should be able to have a dialogue with the patient and the relatives if you face such a situation. There has to be a definitive sampling and vitreous clearance. Direct microscopy, culture, and PCR as the armamentarium may be available, and a diligent follow-up, I think, is necessary in all cases of endophthalmitis or suspected endophthalmitis and imposters. Thank you so much for giving me the opportunity to present a few slides from my side. Thank you.
Thank you. Thank you, Dr. Vivek. It was a wonderful presentation, a nice eye opener about how to be more suspicious and not go by the very first presentation and look for beyond endophthalmitis in certain cases. So without much ado, because of want of time, we will go to Dr. Saravanan, who is a senior vitreoretinal surgeon from Arvind Eye Hospital and a dear friend. Yes, Saravanan.
Sir, I'd like to thank Prashant sir as well as Tinku madam for giving me this opportunity. So I'll be just more or less sort of a rehash of what Dave talked. So a lot of times we see that after a successful treatment, the infection keeps coming back. So when you have such a recurrent infection or reaction in the anterior chamber, so just giving a few case examples of what to suspect, so to give an idea of how to go about in these cases. So it could be not an infection at all, it could be an inflammation with some sort of either retained lens matter, either in the peripheral bag area or in the inferior vitreous cavity, or it can be a recurrence of inflammation after a successful control of infection. This is sometimes we quite commonly see after a successful treatment of a bacterial infection. When you're tapering off steroids a little bit faster, this tends to happen. And then we come to the improper therapy. And then fungal infections by default, they tend to be much more recurrent. Also, sometimes you have to look at the atypical organisms. This is one of the case examples. The first patient, the first right eye had undergone cataract surgery almost 6-7 years back. Old man did not want to get his left eye operated, but he came with the inflammation. And it looked like it was aphakic, and we were repeatedly asking question about whether he had undergone a surgery where IOL was not implanted, and he had recurrent, first treated with the steroids, then came back again after the steroids was tapered. And then when he did an ultrasound, we were able to locate you can see probably in this photograph, you can see a small edge of the nucleus which is there. This was actually a sort of a leaking Mogagninian cataract where all the cortex has liquefied and leaked out. The capsule has ruptured because of the intumescent lens, and a small residual lens nucleus bit is just hidden behind the iris. This is published in one of the reports. You can see that that is the superior iris, and you can see the inferior to the inferior iris. You can see that there is a small shrunken nucleus, which was the source of recurrent. So routine ultrasound missed it, so we had to do a standoff ultrasound to identify this. This can be sometimes either hidden lens matter, either in the sac area or in the inferior vitreous, can be a cause of recurrent postoperative inflammation, which can sometimes be mistaken for a recurrent infection. And as I told you, fungal is one of the commonest causes of recurrent infection. This is a published report where they were able to, they had multiple recurrences, initially thinking that it was a bacterial infection. Then once it was having multiple recurrences, they went in for IOL removal, and they were able to show that the surface of the IOL, they were able to culture the Aspergillus fungus, fumigatus fungus, and after successful treatment with the multiple injection of voriconazole as well as oral supplementation of antifungal agents, they were able to control the infection, and they were able to implant ACIOL after successful control of infection after 10 months. This is one of our own cases, a young boy who had an injury with the coconut leaf, and he had initially came with a corneal abscess, and after successful treatment of the corneal infection, there was recurrent anterior chamber exudates at the edge of the iris and just behind the iris, and that was diagnosed to have a lens abscess. And finally, the removal of the lens and whole bag, and with the repeated intracameral injections, he was able to recover and save the eye in this patient. So atypical fungus, this is one of our local general physician who underwent multifocal IOL, and he came with drop-in vision after around 3 months after the surgery. You can see the typical atypical formation of this fungal colonies. So whenever I see, normally in a fungal infection, we tend to see yellowish exudates. But when you see a atypical colony appearance that you will see in a petri dish, then there can be two issues. One, it's a sort of a atypical fungus, not the routine thing which we see, or else the patient's immunity is very much poor. Like in sometimes very old, frail people, I tend to see this. So if you have a colony-like appearance, you have to think either it's atypical fungus or a very decreased immunity from the patient's side. This patient initially tried to save the lens. The patient was not willing for IOL removal, but as previous speakers told, whenever suspected fungal infection, it's always better to remove the bag as well as the lens so that the recurrence can be prevented. Initially, he was having a little bit success, but again came back, and finally we had to explant the IOL. And after success, multiple injections and oral, usually we supplement the oral fluconazole or vonoprazole if the patient can afford it, or if it's a very severe infection. And finally, still FAQ is not willing for a secondary IOL for almost more than 3 years. But anyway, so again, we published this was a very rare fungus, Exophiala dermatitis, which was a rare fungus, and we are able to publish this. And one other cause of recurrent low-grade infection is Propionibacterium acnes. So again, this can be either after surgery or it can be after following a YAG capsulotomy. And this can also be a source of recurrent inflammation or infection, which can usually it's not so severe. So usually it is assessed to be an inflammation, but later on, when there are multiple recurrences, when you do a tap, you may be able to show the PCR can pick up the Propionibacterium. Culture is not always that very great. And repeated Vanco usually is very sensitive to Vanco. So Vanco and Dexa can help to take care of this. Rare instances, you may want to remove the bag and the IOL. And one more common recurrences which we see in our side of the way, no though it's not seen in North India and especially in Tamil Nadu and South India, we tend to get a lot of nocardia infection, especially in frail, very old, frail sunken globe patients. There's one of patients, a 76-year-old lady. You can see usually the conjunctiva was quite wide, not much congestion is seen. Antechamber reaction will be quite less, but you'll see these colonies either in the antechamber or adherent to the paracentesis port or the superior section wherever you made it. And we were able to, usually in this case also, I usually directly go for a bag and IOL removal along with the anterivitrectomy. And unfortunately, this patient went in, had developed scleral abscess at the site of the infusion port. But finally, after curettage and cryotherapy, we were able to control it. And now the patient is still aphakic with a discoloration of around 624. So again, this is a big series of cases was published from Arvind Madurai. They had, again, it's not quite commonly seen in North India or outside India, but we tend to see a lot of cases in Tamil Nadu. So one more rare instance, which we had a large series of almost close to 200 cases of cluster infection in one of the centers in Madurai, not Arvind, but outside. So it was from the, again, this was published by the alert was sent from the AWS also. It was a kind of infection was present in the topical medication, which was used for topical phaco. So all the patients who underwent topical phaco developed the infection, late onset infection, but the who underwent block did not have this. So you can see a lot of cases, almost 200 cases over a series of cases of over a period of 3 months from the same surgeon. And a lot of patients had recurrent infection, especially at the site of the corneal tunnel, and a lot of patients we had to go for a sort of a patch graft to take care of this.
A minute left.
We were able to save most of the patients from this series. So again was published the rare case of Burgholderia cepaceae cluster from a topical medication, a topical anesthetic agent. So also when you have to think about other rare organisms, like in this case, is a published report of a recurrent non-tuberculous mycobacterial endophthalmitis, which is a cause of post-operative infection. Again, it went in for a kertoplasty, but an IOL bag explantation was able to control the inflammation. In the Ziel-Nielsen stain, you are able to appreciate the acid-fast bacilli, which again showed the presence of the non-tuberculous mycobacteria. This is the last case. It's actually a case of our own cataract surgeon's own uncle. He was also a general physician. He underwent vitrectomy, but the surgeon himself was his nephew. And after surgery, he had a severe vitritis. And again, after initially tap, nothing was responding. Then went in for a vitrectomy, but it was totally atypical. It was a multiple, like a white dust material in the vitreous cavity, and unlike what you normally see in the clumpy exudates. And you can see the peripheral vitreous cup, which is snowy white, which after the initial vitrectomy. So second, we tried to do a lavage to take care of this. But finally, when it was so atypical, we were able to prove it was actually a lymphoma case, not an infection case. So, but unfortunately, developed other series and he expired after 1 year after this episode. So we were able to salvage the eye after giving intravitreal methotrexate, but finally other things he didn't survive the disease. So my take will be to, whenever having a recurrent infection, try to think of other things apart from infection also, and also other rare organisms apart from the routine organism which you see. I'll stop here and we can have the discussion. Thank you, sir.
Thank you.
Thank you, Dr. Saravanan.
These cases, yeah, very atypical cases. Fantastic collection. Over to you.
Yeah, so we'll have a discussion in the end since we're running short on time. And now we move on to the great debates. So here we'll be debating some controversies in endophthalmitis. Just a disclaimer, the views of the speaker may not be their own. They may simply be doing it for the cause of debate. And for the first debate, we are debating managing endophthalmitis with vision less than finger counting 1 meter. That is a severe case of endophthalmitis. And we have Dr. Himadri Chaudhary, who will be speaking for intravitreal antibiotics. Dr. Himadri Chaudhary is a consultant retina and vitreous at the Chaudhary Eye Hospital and Research Center in Silchar, Assam. And let's hear what he has to say to defend this, his take on giving intravitreal antibiotics first.
Are my slides visible?
Yes, they're visible. We hope that at the end of the debate, we have some clear take-home messages for the audience. So let's see.
Doctor, you can click on the play button.
Yeah, but the Zoom keys are blocking the play button.
You need to, on a Mac, you need to give a permission. I think it's been done for the first time.
Drag it out of the, it's draggable, that Zoom controls are draggable. You just press and hold and you can.
Okay, fine. Yeah, that's good. Thank you. Thanks a lot. Okay, thanks a lot, Dr. Tinku, Dr. Prashant, for giving me this opportunity. Thank you to the ARC team. I'll be talking about managing endophthalmitis with visual acuity less than finger counting 1 meter. And I'll be talking in favor of intravitreal antibiotics first. I have no financial disclosures. A picture like this immediately after surgery is very scary, but we have to know how to manage it. The goals of treatment are to kill the invading organism, arrest the damage caused by exotoxins and endotoxins, and arrest the host inflammatory response. Most of our knowledge of endophthalmitis is based on the EVS study, but it was published way back in December 1995. And does this hold true even today? Well, EVS says that there is no role of systemic antibiotic, but the ground reality is not that. Today, we do prefer systemic antibiotics. EVS says that routine pars plana vitrectomy is not required when the visual acuity is better than PL, and PPV is of substantial benefit only in those patients where the visual acuity is PL. However, a modified EVS protocol was published in August 2017 by the Survey of Ophthalmology, and this is the protocol I follow. Whenever there is a diagnosis of endophthalmitis, immediately we have to go for an injection along with vitreous tap. I prefer a vitreous biopsy. We have to assess the clinical response after 24 hours. And in case there is a good response, we will continue with the same treatment. And in case there is a no response or a poor response, only then there is a scope of vitrectomy. Otherwise, just move along. So I prefer the single port vitreous biopsy. It's a relatively easy procedure. It yields undiluted vitreous sample. And especially when the patient has a visual acuity better than PL and we are not planning to do a complete vitrectomy, it is a good choice. However, we have to make sure what drugs we are choosing, because in the scenario in India, which is different from the EVS study, is that we get a large portion of gram-negative organism, almost up to 50%. And among these gram-negative organisms, there is high degree of resistance to ceftazidime and amikacin. So my preference is vancomycin along with imipenem. And in most cases, I prefer to go for a dexamethasone injection as well. So these are a couple of cases where just a vitreous biopsy along with intravitreal injection of vanco and imipenem had very good results. A few more cases. Even in cases of traumatic ENDOPH, sometimes I just do a vitreous tap and injection, varying from patient to patient, and we do end up with very good results. There have been multiple studies which have shown that early vitrectomy, even in patients with good vision, do yield good results, but none of them were randomized controlled trials, so they do not move to level 1 evidence. Unless we get results of the endophthalmitis management study done by Hyderabad LVP group, we will not have a solid evidence. So why not go for a primary vitrectomy? Because it's mainly a blind procedure. There is the necrotic fibril retina, very high chance of iatrogenic break and causing a retinal detachment. Also, preparing for the surgery delays the process, and we should go immediately for an injection as early as possible. So I'll finish with the part of the Hippocratic Oath, which says primum non nocere, which is first do no harm. In our hurry to clean up the vitreous cavity, clean up the organism, and give a very good result immediately to the patient, we should not do any harm to the patient. Eventual visual outcome. Thank you very much.
You can stop sharing, and I request Dr. S.P. Tiwari to now defend it. He would like to go for vitrectomy immediately. Why not?
Yes, sir.
And then we will have a final opinion from all the seniors like Dr. Preetham, Vivek, Saravnan to comment on it after the debate.
So thank you, Prashant sir, Tinku ma'am, and this AIS ARC for having me here for this debate. I would go, yeah. We have done a good
Dr. Tiwari, just get your video off.
And we are expecting that next day the patient is getting 6 on 6 unaided, or just a moment.
Dr. Tiwari, आपका network poor है, आप video.
Yes, sir. I have off the videos. Yes, sir. So suppose we ended up with this kind of situation where the ultrasound shows a large exudate in the vitreous cavity and the patient is not having a good situation like this. So what to do in such scenario? As my colleague told that we would go for immediate intravitreal antibiotic, there is no doubt about that. At the first opportunity, any infection need to be treated by a suitable antibiotic, and preferably if a local antibiotic available to the site of infection, that works best. We all know as a general physician. But if it works, then we all are very happy. But what if it doesn't work? Many a times we are having a lot of bad infections which may not be just treated with intravitreal antibiotic or supportive treatment, and then we can't sleep. We are hoping that okay, our patient just have some good vision or something. So what we need to do? We think as a retina surgeon, we should go all guns blazing to control the infection. And what is the main way of controlling any infection is to debulk the infection. Unless we are going to debulk the infection, then we are not going to succeed in our effort of treating that that infection. And after clearing vitrectomy, we may have some suitable expectation, and we may a little bit relax. So why IOB is the initial management, we all know, but it is empirical and it is not specific, as we don't have that culture report just before injecting that antibiotic. It never reduces the infection load. So a proper sample for microbiological testing cannot also be taken safely and adequately if we don't go for vitrectomy. My colleague took vitreous biopsy through one single port, but suppose we are taking the patient to OR and putting one trocar cannula to take a vitreous biopsy, why can't put 2 more trocar cannula and just clear the debris and exudates also, rather than just taking a small sample and putting antibiotic and leaving the case half-heartedly done. So endophthalmitis is a devastating complication, and we need to answer a lot of vision saving, eye saving, and medical legal questions also. We cannot afford to offers suboptimal treatment in modern
1
era of
minute.
vitrectomy. Because IOB was followed by conservative treatment in older days, but now vitrectomy machines are very good. We are having trained vitreoretinal surgeon and good surgical setup in every nooks and corner of our country, and complications associated with vitrectomy nowadays are very less. So a lot of recent studies have been shown that early and complete vitrectomy is going to give you a better outcome as compared to just doing a vitreous biopsy and injecting some empirical antibiotic and waiting that antibiotic to work as a miracle. A lot of review of literature also showed the similar thing. And in modern days of these vitrectomy setups, I don't think we ever hesitate to do a vitrectomy, and it appears a safer thing to do at the earliest if we have even with the little bit of the view to go inside and cut out all the exudates and remove it all. So I would leave my debate at the end by putting just a question to all the panel that would you inject and wait for response and then go for it if any of your own near and dear one develops this unfortunate complications. Thank you all, sir. Thank you for that opportunity.
Great debate. In fact, now I would request the seniors like Dr. Luthra, Dr. Saravanan, and Dr. Preetham to just say a few words so that there is a carry home message for the viewers.
Yes, sir. So I prefer I side with the Tiwari, sir. We here in Arvind are quite aggressive, especially after the MIBS era. Our success rate and the risk for surgery is very less. So rather than waiting and seeing whether the injection is working or not, especially in eye, because even a short delay can cause significant vision loss. My technique is to go all guns blazing as Tiwari basically put it up. I side with Tiwari.
Preetham.
So I'm going to be diplomatic.
Okay.
I'm not going to side with anyone. But, because there can be situations where, there's hardly any vitreous involvement and your intravitreal injections, you may not even need to repeat it. Even one single intravitreal may work.
The situation is counting finger 1 meter.
No. So I'm coming to that. And having said that, you could have a situation where you could be looking at the retina, you could have a slight view of the retina, but then it is better to, because like Dr. Sarvaran said, with the modern MIBS techniques, EVS was published in 95, where we were 20 gauge vitrectomies and we would suture the ports. In fact, you would have a situation where the endophthalmitis would have less inflammation, but a post vitrectomized eye would look more inflamed, in that era. But currently that is not the situation. In MIBS, you have such fantastic results. So I'm going to flip the whole thing on itself and say that rather than looking at the patient's vision, I will say, what is my vision? So I'm not saying what is my visual acuity, but I will ask myself, what is my vision of the posterior segment? So if I'm seeing the disc clearly, let's say the optic disc clearly, if I'm seeing the first retinal blood vessel, first order of retinal blood vessels clearly, that is telling me few things. That is telling me my cornea is good. My IOL and my bag is not involved with exudates and stuff. My anterior segment is not so inflamed. My vitreous is not so inflamed. So if I'm looking at the retina, I'm seeing a healthy retina, which is not necrotic, not exudates, then I would probably go with intravitreal injection first. But if my vision of the posterior segment is poor, my cornea is infiltrate, I have a corneal infiltrate, ring corneal infiltrate, AC exudates. If I have a bag full of exudates, my ultrasound is showing a lot of exudates, I think there's no question of waiting over there.
I will have a last word from the senior most vitreoretinal surgeon in today's gang, Dr. Shobhit sir.
I totally agree. I would go ahead for an early vitrectomy if all the factors are unfavorable. And because here the question is to save the eye and salvage whatever vision is possible. It's very simple. And in today's era, we are more inclined towards earlier vitrectomy in these cases.
Thank you, sir, for summing it up so adequately. Now, Dr. Tinku, over to you for second.
Yeah. So thank you. We have now the second debate. This is vitrectomy and endophthalmitis. And we have Dr. Girish Velas, a young enthusiastic vitreoretinal surgeon all the way from Panaji, Goa. And he would be talking about co-vitrectomy. That is his preferred mode of treatment. Dr. Girish?
Yes. Good evening, and thank you, Dr. Prashant sir, Dr. Bali, and team ARC for giving this opportunity to present. I'll be talking about core vitrectomy. So by definition, core vitrectomy involves removal of central vitreous gel, which we can say as debulking to the maximum extent possible. So there is no PVD induction, no base excision. So now, when we are talking in this we are talking about the modern vitrectomy instruments, modern viewing systems, and cutters, and this gauge and that gauge, with them so many modifications and these things. They are justified, yes, but many a times, whenever we have the endophthalmitis presentation can be delayed many a times. The referral can be delayed. So that leads to very hazy media and poor visualization of the retinal structures, or the primary blood vessels, or first order blood vessels, or the optic disc. And many times when we are able to view the retina, it might show a lot of inflammation, necrosis, or the fragility of the retina might lead to iatrogenic retinal breaks, which by doing the thorough vitrectomy, we might be damaging more rather than benefiting. The challenges are more in young patients where PVD induction is difficult, and with the inflammation which compounds it. In a traumatic endophthalmitis case, where there might be organic foreign body, which will compound with the, if it's a metallic foreign body with the damage to the retina, then in that scenario, doing the PVD induction or doing base excision might be more damaging. So the analogy of the core vitrectomy can be more of in terms of the general surgeons, which assess the abscess in terms of, like, they do marsupialization, they do incision and drainage rather than completely removing, which takes care sometimes the systemic antibiotics, the local antibiotics. They do have a role in case of treating the particular disease condition. So as my colleague in the first debate did present in terms of talk about the Latin phrase primum non nocere, which does mean that first do no harm, which is a fundamental bioethical principle which is taught to us in medical school, where we know that every weapon in a physician's armamentarium is a double-edged sword. So every cure can have a potential harm. Maybe so when we know that we are going to cause more harm, why not restrict ourselves? Why not wait for maybe just do debulking initially, intravitreal antibiotics, and wait for the next opportunity to do subsequent second stage procedure maybe. So when I was given this talk, it was like given this opportunity, I did a literature search for this sort of for this core vitrectomy in endophthalmitis. Unfortunately, I didn't find article which was specifically focused on core vitrectomy only. Everybody is talking about early and total vitrectomy, complete vitrectomy, which I agree. But there are many presentations where it is difficult, where by doing such adventurous procedures might be more damaging, more than the rewards which we are going to get. So it was like I will feel that I felt like I'm going to defend a criminal actually here in terms of the condition. But and the initial talks when we had, when past president also was saying that what this debate is there where core vitrectomy is going to, we are going to talk. But the subsequent talks by in between, where Dr. Shobhit sir did mention when core retinectomy, the chorioretinectomy condition was talked about, where we might be doing more harm. So those things were kind of healing kind of thing, which gave me an impetus to talk more freely for this sort of particular condition.
Thank you, Dr. Girish, for wonderfully defending your own part. In fact, the debate is not meant to be, we all as a surgeons understand that it is always a matter of, the situation which demands what you should be doing, but we have to send them a clear message to the audience at the end of it. And that's why we have to have an extreme situations you have to defend. Now over to another friend of mine, Dr. Vishal Agrawal, who is going to talk about, about the total vitrectomy. He's an aggressive vitreoretinal surgeon from Jaipur, with so many awards which he has to his kitty.
Thank you, Prashant sir. Girish, can you stop sharing your screen?
Just 1 second, sir.
Thank you, Dr. Tinku. And I'll be speaking for the adventurous procedures and aggressive surgeries like complete vitrectomy.
That suits your personality, I believe.
I hope it's not a negative comment.
No, not at all.
Okay, 1 second. So just a brief, we all know that endophthalmitis is a severe and purulent intraocular inflammation. And regardless of the etiology, both the organism and the inflammatory response it invokes is very harmful to the eye. And the crux is early detection and prompt management. So what is the prompt management? Of course, recognizing the condition early and executing an optimal therapy. And what is the optimal therapy? The optimal therapy actually is multi-pronged. It is supposed to kill the organism. It is supposed to remove the inflammatory debris from the vitreous cavity. It should block the inflammatory cascade and its effects on the retina, treat the complications and minimize future complications. So it's not, just one thing which we are targeting. And there are intravitreal injections, whether it's core vitrectomy, whether it's complete vitrectomy, any optimum therapy should aim for these points. So this can be achieved with the core vitrectomy or with the complete vitrectomy, which I'm going to favor, which is my preferred way. And the views are mine and not just for the sake of the debate. So coming to EVS, a lot has been said already. It was a different era and vitrectomy was reserved for the most severe cases. And it was limited to the anterior vitreous. So actually it was said that you should remove 50% of the vitreous and do not do a PVD injection. If already it's present, it's okay. If it's not present, you should not attempt to excise the cortical vitreous. And the 50% which was removed was actually the anterior vitreous. And the whole debris and the inflammatory smug was in the posterior vitreous. So we have come a long way from the primitive viewing system which we had in the 90s and the large gauge instruments. And so this study, although it was a very meticulous and a systematic study, it was from a different era, and the conclusions and the inferences are obsolete in today's world. So coming back to the complete vitrectomy. So why perform a complete vitrectomy? So the inflammatory, it's a simple logic. The inflammatory debris and the pus, is heavy and it typically settles over the macula. And only by detaching the posterior hyaloid, you can gain access to the retinal surface and remove all the subhyaloid pus and debris. And in the sono, you might be tempted to believe that it is a PVD, but believe me, there is never a complete PVD in endophthalmitis cases. It's very rarely present. Most of the time it is vitroschisis, and you have to induce that to gain access to the subhyaloid space. And complete vitrectomy does not imply a base excision. It implies a PVD and removal of the vitreous posteriorly, and as safe as possible, a peripheral vitrectomy. And I'm not being heroic. I'm not being carelessly overzealous. It's the right thing to do. And as my colleague said in the previous presentation, there are no articles for justifying core vitrectomy if you search the literature. There is an ample amount of literature supporting complete and early vitrectomy for endophthalmitis. And the results say that there is the visual acuity, the anatomical outcome is far superior in complete vitrectomy, and the recurrence rate is far less than core vitrectomy. Just a short video to justify what I'm trying to tell. This is a post Ozurdex endophthalmitis. It was a fulminant endophthalmitis, day 3 of Ozurdex implant. As you can see, the view is always compromised in the endophthalmitis case, but if you are meticulous, it is enough. And with the excellent viewing system, you can see the retinal surface. And I'm just inducing the PVD like I would have induced in a normal case. You can see the crisp view of the retina and the maneuvers I'm doing, the excellent instruments and the excellent cutters which we have. It's so safe to induce a PVD, and it's not very difficult. You don't need a high section to induce PVD in these cases because it's already an inflamed eye, and it's just a mild section lifts up the hyaloid in these cases. This is the last video. This is a fungal endophthalmitis. As you can see, it's so fulminant. I cannot see the retinal surface. After doing core vitrectomy and seeing where the surface of the retina is, I gently give just a nudge over the disc, and the hyaloid is detached, and you can see the retinal surface at the end of the case, and the results are excellent. So to conclude, there's always a fear of iatrogenic retinal damage, and that is the logic and debate that goes against a complete vitrectomy. Especially in surgeries where visibility is poor, like end of vitrectomies. And I agree, it is not prudent to be over aggressive in every case of endophthalmitis. but improved machinery and excellent viewing system have made the above scenario a rare thing. And accessing the subhyaloid space by doing a total vitrectomy is the most important difference, which is there in the final outcomes and recurrence rates. To conclude, complete and early vitrectomy should be the standard of care in today's management of any case of endophthalmitis. Thank you so much.
Thank you, Vishal. We will have two comments. One from the young, enthusiastic boiling blood from Dr. Srinivas Joshi from our ARC team, and followed by senior person, Dr. Shobhit Chawla, who is mature enough, who will give the last word. So, Srinivas, are you there with us?
We are not mature enough.
No, don't take it in a right way. We are just trying to have all the people, all age group people's opinion.
Sure, sir, sure.
Srinivas, are you there with us?
Yes, sir, I'm there.
Yeah,
but since I'm traveling, the network, I don't know if it is not good, then you can switch over.
Yeah.
Sir, I think it's a wonderful talk by both the surgeons, and I agree with the most of these points, definitely. But whenever an opportunity is given,
I think I think we lost him. I think can we have Srinivas? Can you? We can't hear you. Hello.
Okay, now you are able to hear me, sir.
Yeah, correct. Please.
Okay, so I definitely agree, because I love to do as much as complete vitrectomy as possible. But if there is an endophthalmitis with retinal detachment, I think the only way to go ahead with this to do as much as vitrectomy as possible, because completely doing a base shaving and creating a break in the inflamed or the necrotic retina, which is definitely the laser in those aspects. So that's better in case of endophthalmitis with retinal detachment. But if it's endophthalmitis with no much retinal involvement, then I definitely go ahead to do a complete vitrectomy, as much as base shaving as possible. And and my choice would be to put a silicone oil. And also, if it's non-KOH, then I prefer to use an intravitreal dexamethasone also in some lower dilution quantities in these cases, but confirm that there is no KOH in that patient as well.
Thank you, Srinivas. I thought you would be supporting your dear friend Vishal, but let's see. Now, final word from Dr. Shobhit, sir. You dished it.
I think Dr. Girish Well's point was also valid, but Vishal, with his very mature last slide, summed it all up. I think his last slide sums everything up. Wherever possible, in today's time, we try to do as much as possible. I'm of silicone oil in these cases, because I like to keep my endophthalmitis cases in station, and I like to see them at least 3-4 times before they leave. And if I feel, I think that can always be done in the second sitting with a lavage. But blanket use of silicone oil is not my choice, but definitely as much a good vitrectomy and where easily and safely removable the posterior hyaloid. I would go for it.
Okay, thank you, sir, for summing up so beautifully. Now it's time for us to move to the last part of the last debate. And here I'm going to have the final word from younger generation, that is Darius versus Preetham, who will be summing up that debate.
So this debate is about IOL explantation in endophthalmitis, and Dr. Darius Shroff, who is a director and a vitreoretina consultant at the Shroff Eye Hospital, Delhi, will be speaking for always explanting the IOL. Let's listen to him.
Good evening, everyone. I'd like to thank the ARC, Dr. Prashant, Dr. Tinku for this opportunity. And I think now we've heard about almost 2.5 hours of science. So now I thought, when I got the program, I thought there'll be a little fatigue. So I'm going to have a little fun at everyone's expense. So excuse me for that. So should we explant the IOL in endophthalmitis? Yes, yes, and yes. Why should you remove the IOL? If you don't nip end off in the bud, if you leave a nidus or infection brewing, you cause a major harm. So endophthalmitis, like we've learned today, is no worse than a tsunami or a hurricane for this patient. Now you just look at this slide. This is my worthy opponent. This is Shamik. So seeing is believing, but don't believe everything which you see. And this is Shamik, and he may be just be an undercover sheikh for all you know. So don't believe what he says, believe what I say. So I have one point that I think this is, I want to tell my dear esteemed retina colleagues that please don't go into this cataract mentality of holding on to the IOL for dear life. If it needs to get out, please let it get out. Don't hold on to it. Again, I think poor Hippocrates is rolling in his grave. I'm the third person in a debate to invoke the oath. But yes, I say it again, that don't do harm, do what is required. So that is what is important when we are dealing with fulminant cases of endophthalmitis. So we have studies from all over India. This is from the north. This is from the PGI group, where they found a concentration of fungal elements in the bag, the capsular bag. And when they treated these really, really tough fulminant cases of endoph, they were able to prevent recurrence for almost 3 years in these patients. So this was vitrectomy and IOL explantation, which helped in these cases. And now let's move to the south of the country. So this is a study from the LV Prasad Eye Institute. So when they found treating the low-grade endophs which were delayed, they found that if you removed the IOL, it allowed earlier resolution, lesser need for intravitreal injection, and a trend towards better functional outcomes. So we have proof from both the north and the south of our country. Let us see some of our own cases. So this was a lady who had inflammation 3 weeks post-cataract surgery with bouts of high IOP. You can see the inflammation in the eye. She underwent a vitrectomy elsewhere, 5 rounds of intravitreal antibiotics and antifungals. She was very unhappy, 4/60 vision. Lo and behold, once a revit and IOL removal was done, you can see how beautiful the eye became. The vision was restored, and she's been stable for 2 years since that procedure. Second case was a case which even Dr. Gagan alluded to. This was this is part of our series of patients who had COVID, but this was somebody else who had COVID and had a vitrectomy initially. And lo and behold, the right eye was saved. You can see the right eye. Left eye, unfortunately, was lost. And this right eye would remain stable for 1 year. This was a pseudophakic patient. When he came back with this worsening and horror, and this was the kind of condition he came in. So I would ask my colleagues, this is the kind of anterior segment OCT of this patient. This was the kind of patient who had to have the IOL removed. And once this the lens was removed and we removed the fluffy material from the retina, we found that candida grew around the IOL itself and in the bag. So once the IOL was out, this patient was infection-free for 15 months. So to conclude, I would like to just say that, I mean, we have to agree to disagree on certain things, but in cases of fungal endoph, I would say always remove, because it's an important take-home message. If you have chronic bacterial endophthalmitis, mostly, and I would say that don't hold on to your lens. I mean, if it has to go, it has to go. In acute bacterial, maybe we agree with Shamik a little bit, but again, if it's non-resolving, just do it like the people at Nike say, please remove the IOL. Don't hold on to it for dear life. So thank you. And this, in fact, was a picture which Shamik and I took at the Retina Imaging Congress in Trivandrum last month. So I'd love to hear what he says about this. Thank you.
Wonderfully presented. Shamik.
So next we have Dr. Shamik Mokaddam, who will be speaking on never explanting an IOL. Dr. Shamik is the head and at the VR services at Anjani Eye Hospital, Nagpur. So Dr. Shamik, let us have your talk.
Yes. My screen is visible, isn't it? I hope it is.
Yeah.
I'll just go on to my view on explantation of the IOL. Darius has summed it very well, but then he spoke only about the chronic or the long-term late endophthalmitis. Let us, we know that IOL implantation surgeries are the ones with acute endophthalmitis, and most of the surgeons are going over to PPVs nowadays. Then the doubt comes whether to explant or not to explant. And as you can see, I was sitting and thinking about it. We have all spoken about early PPV. We have all spoken about complete and early vitrectomy. And but then once we remove the IOL and we give the eyesight to this patient, he's very happy. Yes, he is very happy. But what about the aphakic correction and the problems therein? What about the second procedure risks, second procedure and the risks involved? And what about the other eye? What if the other eye is a pseudophakic and then the patient stays with one eye having a aphakic glass and the other eye having a normal glass. How would that patient manage things? So then in acute endophthalmitis, there is a very small cohort retrospective analysis which was conducted in Tianjin Medical University. And they found out that, under systemic antibiotic treatment and timely diagnosis, vitrectomy and silicone oil tamponade without IOL removal, it is safe and effective method for acute post-cataract surgery endophthalmitis. A survey was conducted by Yan Hui from the Department of Ophthalmology in Shizing Hospital. And he found out that, 73.8% surgeons did not want to remove the IOL. Agreed, the cohort was very, very small in these studies. And but then a better instrumentation, better visualization, better antibiotics, it all obviates the need for IOL explantation in acute endophthalmitis management. And of course, we have a very happy patient. Yes, as Darius had already put up, in chronic or late endophthalmitis, the management is different. The organism is sequestrated in the capsular bag or on the posterior surface of the IOL. And most authors, especially the group from LV Prasad, have suggested an early intervention with IOL explantation and capsular bag removal, along with PPV and intravitreal antibiotics for better results and less recurrences. So I would say, let's rephrase the whole thing. And in IOL explantation in acute endophthalmitis, I would say it should be avoided and can be taken care of without removing the IOL. In chronic endophthalmitis, though, it should be done early and always. Thank you.
Shamik, for very well summarizing. So now we will have an opinion from two of our most, Mr. Kul Rohit, vitreoretinal surgeon, that I can say our Dr. Saurav Luthra, who will make a final comment, followed by a fiery vitreoretinal surgeon, that is Virat Kohli of vitreoretina, that is Sangeet Mittal. So where is Saurav? Saurav, can you make a comment, please? Okay. So we are left only with Virat, the fiery.
So we can ask Dr. Dave, since he is the one.
Yes, he's another.
He's the one. Dr. Dave is the one for explanting IOL. So let's hear his point. Is he there? No.
Okay. We will have from Dr. Sangeet then.
Thank you, Prashant. I think life is not always black and white. There are always shades of gray in between. For me, I won't go for explantation of IOL in all cases. Again, as Shamik has pointed out, like there are two different types of endophthalmitis. One is acute, one is chronic, and the management is totally different in both the patients. The prognosis is better rather than in acute cases, the prognosis is bad. So I think not in all cases, I will never explant an IOL.
Okay, great.
We can, Dr. Ashish Lal, we can ask him.
Ashish, he is a fiery man. I want him to explant. Ashish?
No.
Okay. I think it's time for us to say wind up. But before that, Dr. Tinku, can we have from Dr. Shobit and some senior persons get answered few of the queries which are in their chat box?
Yes.
Prashant, can I make a comment on this IOL explant?
Of course, of course.
Of course, you should.
So, I'll just have a perspective on it. Here in ENDOPH, we are removing the vitreous because the vitreous is a substrate where the organism is growing. So we are removing the vitreous. I think the material of the IOL is not really a substrate where the organism is growing. So as a rule, we need not remove the IOL in every case, like Dr. Sangeet said. I think if I have to remove an IOL, it will be with an objective. For example, I have done a vitrectomy, and let's say I have a recurrence, like in fungal ENDOPH or nocardia, where my objective is to convert the eyeball into a single cavity, so that my antibiotics reach the entire all the confines of the eyeball. There I'll remove the IOL to convert the eye into a single cavity. Situation where I know the organism is in the capsular bag, like say P. acne. In fact, in P. acne also, you could probably do a nice a hole in the posterior capsule, inject little intracapsular antibiotics and still control it, leaving the IOL behind. But if that's not going to happen, then I will remove the IOL because I know the organism is in the bag. even maybe for some fungal endophthalmitis cases. So I think I will remove the IOL with a very an objective in my mind that I have to achieve something for removing by removing the IOL. So I'll leave it at that.
Okay, over to you, Tinku. We get
So we have some questions. There's a question about how to differentiate fungal from bacterial endophthalmitis on clinical examination. Are there any pointers to that?
Shobit sir.
Yeah. Well, the eye is much quieter. We see flocculent material. Many times it's limited to certain sectors of the vitreous cavity and not widespread, as in bacteria. And the eye is far more quieter. These are, and the time of occurrence, the incubation period is normally long in a fungal endophthalmitis. These are the main points.
The other question is, do you give oral voriconazole with intravitreal voriconazole? Always.
To start with. But if I see that a patient is immunocompromised or has had treatment for some other fungal foci in the body, I consult the treating doctor or the physician, and then these patients are for about a year on voriconazole oral. They are not for short periods. So it's a long-term treatment then. And along with that, they also have continuous monitoring of their KFT and LFT profile. So just taking that decision on a localized disease for the eye, I don't think is justified. I would rather give repeated intravitreal voriconazole injections than go in for systemic treatment straight away.
One question is, and do's and don'ts with respect to immediate OT sterility protocols in a situation of cluster endophthalmitis. Dr. Preetham, Dr. Sangeet, can you just guide the people? Post cluster endophthalmitis, the do's and don'ts about OT sterility following a cluster.
I think we have a very good. I think AIS has already laid down guidelines, following cluster endophthalmitis. So in following a cluster endophthalmitis, I think most important is to make sure that your OT sterility, to find out where it is compromised, to take swabs from various places from within the OT in your wash area. And it is a lot of protocols involved in that. Maybe Sangeet, you can tell
I
us.
think the most important thing is to find the source of the infection. Once you track the source, until then, I will advise to stop the OT till you get hold of the infection, where it has come from. And once you got the source, then you treat the source with whatever, like if it is in the OT air, you have to treat it separately. If it is in some infusion or some fluid which are you using, you have to change the fluid. I think the most important thing is to track down the source. That is most important after you get a cluster infection.
See, I would like the viewer to remember, the ophthalmologist to remember, if you ever have a cluster, you are supposed to inform it to the NPCB as well. So if you have I don't remember the exact number of cases which, if they call it a cluster, which needs to be reported to government agency, first foremost thing. Second, stop the surgery, as Dr. Sangeet has very rightly pointed out. Third is to look for the cause. And fourth, most important thing I feel is to take help of your fellow colleagues from other hospitals, get it certified, get the help of some vitreoretinal surgeon and an investigating team. So on paper, your documentation that you have done a proper probe and looking for the thing is equally important in this era of medical legal.
Yes. Documentation is
documentation that you.
So most of the other questions are about IOL explantation, which we've dealt with already in the talks. And fungal endophthalmitis.
Yes, steroids with suspected fungal, should we be injecting?
Yes.
Is it safe to use steroids when you are suspecting fungal? Was the question from Professor Kanandikar.
Dr.
I think steroids should be avoided. If you've already established in microbiology it's a fungal endophthalmitis, definitely avoid steroids. And even if you're suspecting fungal endophthalmitis, I think steroids should be avoided.
On the contrary, there was a study from PGI group which have suggested that if you have caught hold of the fungal and you have given an adequate antifungal cover, you start steroids along with that antifungal treatment.
I remember that study, Professor Amod Gupta's.
Yes.
Yeah.
So what would be the consensus, sir? What would be the message which should go?
Till you don't get that fungal sensitivity report, I think you should avoid the steroids. Once you have a proper sensitivity report and you start with proper antifungal treatment, then you can start steroids.
And if you look at it, just 0.1 ml of dexamethasone will not make any difference, actually. But because it's a followed norm, you can avoid till you don't get the report.
Okay.
At least the KOH.
True.
So I think it was a great discussion. I think it's time. We have already exceeded by our time limit quite a lot. Tinku, you can just say thanks to everyone and then we can wind it up.
Thank you. So there's one speaker who's written that, can you come out with some preferred practice points, for general ophthalmologists? I think we can look into that. A very good suggestion. So yeah, thank you all.
Not only
For?
An excellent.
Yeah, I think we could do that.
Lots and lots of, I think, overlap.
I think, Dr. Tinku, we can summarize and put it into certain consensus type of a thing, whatever we can, and we can share it on our ARC platform. We
could do that. Whatever the consensus has come out from this webinar, we could put that. We could do that. So yeah, thank you all for this very, very interactive and very, very lively discussion. I thank all the chairpersons for their time. I know we've overshot the time and you've been here very patiently with us. The speakers for their very, very interesting talks. They all stuck to the time limit. So I'm thankful to them. And it's been a great discussion, great participation. Thank you all. Thanks, Dr. Prashant, for giving me this opportunity to host this.
Thank you. I think, Tinku, that is not needed. Thank you, everyone from the bottom of heart from Team ARC. You have all done wonderful job and being patient and making it so interactive and leaving some messages for our audience who were predominantly a comprehensive ophthalmologist. I hope we could enlighten them on this very important topic, which they have to tackle in their day-to-day practices, and they can have better understanding from tomorrow itself for their theaters as well. Thank you once more. So
Thank you very much.
Meeting for another webinar, interesting webinar, niche webinar on the 3rd Saturday of the next month. So we will be revealing the topic very shortly. Till then, it's time for us to say goodbye to everyone.